we are its wings. Our patients come from all over with their attendants and well wishers, dejected, stressed, fearful, and panicking, spanning miles, looking for hope. This is their fight, and we are their wings. Our nurses give up themselves, their hearts, their minds, their hands, their time, and talent, armed with experience, humbled with strength, dressing wounds and changing sheets, and calming nerves and keeping watch. These are the angels, and we are their wings. Our doctors trade in tomorrows. Their aim is more time. They sacrifice
very good afternoon, everyone. Dear participants, it gives me great pleasure in welcoming you to RHL for the Heart Lung Summit 2022. The purpose of this two-day conclave is to gear you up to face challenges in your day-to-day clinical practice. We will start with basics of approaching a patient with breathlessness and differentiating whether the cause is cardiac or pulmonary. We will also teach the interpretation of ABG, ECG, 2D echo and spirometry. These are essential tests in differentiating the cause of breathlessness. The aim is to update you about the latest in the management of respiratory and cardiac disorders. We have assembled few important topics from our conclave and try to give you tips to interpret these investigations, which you will find useful in your clinical practice. It has been provided in the conference bag booklet. You will be pleased to know that this is associated with 4 to 6 RMC credit hours. However, the star event of the two-day conclave is a quiz in which the first prize is an iPad. This one. I so wish I could also participate in this. We hope that the message conveyed in the talks would be put to use in your clinical practice and you go home ready to face challenges and provide the best care and management to your patient. Perfection is not attainable, but if we chase perfection, we can catch excellence. I would now like to invite our chairpersons for the first set of talks. Dr. Ajit Singh sir, to the stage please. Dr. B.K. Meghwal sir. Dr. Ambika Sharma. And Dr. Gaurav Bharadwaj. Thank you, dear chairpersons. The first talk of the day will be ABC of ABG, Practical Tips for Emergency. That will be given by Dr. Narendra Rungta sir. Dr. Narendra Rungta is a national figure in critical care. He has been the past president of Indian Society of Critical Care Medicine and the national chairman of the Intensive Care Chapter of Indian Academy of Pediatrics. He founded Association of SARC Critical Care Society and was its founding president. He is a teacher, guide and examiner in both adult and pediatric critical care. His work on clinical toxicology and tropical fever is acknowledged worldwide. I now invite sir to please come to the stage.
Good afternoon, friends. At the outset, I must thank the Heart Lung team, Rajasthan Hospital, for inviting me for this very important talk on ABG. ABG is a science, ABG is an art, ABG is a philosophy. As many ABGs you will do, as many ABGs you will discuss, so much you will learn. I continue to learn ABG after 40 years into it. So learning about ABG is never complete. It's an ongoing learning because in practice you get variety of cases where interpretation changes in ABG, compensation and various organ involvements leading to changes in acid-base balance that goes on and makes it a little bit of funny for you to interpret it. Therefore, is science, art, philosophy, all everything put into it, right? So, ABG, if you are doing some sort of emergency care or ICU care, you cannot live without ABG, because this is found in almost 9 out of 10 patients that you see in emergency or ICU. Almost every patient would have some reflection of his disease, ongoing problems in his body, organs, which will be reflected in ABG. Therefore, it is one of the most important, rather I would say the most important investigation that you do, and this is one of the first tests you should do always when a patient arrives in emergency, particularly after 6 p.m. and before 8 a.m. That means it's a real emergency, and ABG will give you lots of information. It's a single most cost effective test. There is no other test in the universe that I know which is as cost effective as ABG is in understanding the disease process of the patient who is likely to go into ICU or landed in emergency, because it gives you a handful of information, and whatever happens in the body minute wise it is reflected in ABG. If you do an ABG after 10 minutes from the last sample, you will find some changes which will reflect what is going in his kidneys, what is going in his lungs. Probably if he had problems of lactic acidosis or metabolic problems, oxygen utilization, delivery, everything would be reflected in some or the other form in ABG. Nothing goes unnoticed by the arterial blood. The only condition is you do it the right way and seriously. It takes a minute. It doesn't take more than a minute to achieve the results of ABG, and once you pick up the sample, you can keep indulging with your patient. You know, while the clinician is examining, taking history, and doing some sort of intervention in terms of IV line or putting him in oxygen, nothing comes in way. He can do his job, and somebody comes very silently, does a little bit of aseptic cleaning there at the site, does a test, Allen's test, and picks up the sample, and it's one of the easiest technique. Can be learned in about, once you do it in 5-6 patients, you become increasingly confident how to take ABG sample. ABG report gives the clinician the earliest clue to an ongoing organ decompensation at the renal or respiratory system. So if anything goes wrong in the kidneys, or if anything goes in the lungs, it is immediately reflected in the arterial blood. And once you pick up the sample, it is very eminently reflected there as well. It also gives a significant insight about oxygen delivery and utilization at the tissue level. You are giving the patient 60%, SpO2 is about say 60. The patient is breathing fine, not a problem, and yet you don't get SpO2. The oxygen, you increase it to 100%, you increase it to say high flow mask, or even put him on NIV or HFNO, still you find that SpO2 is not improving, everything else is fine. But the ABG would immediately give you significant clue where you can exactly determine whether it is a problem of oxygen delivery or oxygen utilization. It's a peripheral organ problem, if it is just a delivery problem or utilization problem, and there are clues hidden. I would rather say once you get practice of it, it's not even hidden. So this looks complicated, but this is not complicated. Now if I try to explain to you, you know, this is a renal tubule. The central portion is the lumen of the tubule. This is a cell, this is a cell, this is the capillary on the either side, and this is the lumen. Now the function of the kidney is to generate bicarbonates, conserve sodium, remove acid and remove potassium. That is the simple thing to be understood, and therefore hydrogen would go into the lumen of the tubule, bicarbonates will be manufactured and they will be absorbed. Simultaneously bicarbonates are also manufactured in the cells and it goes into the capillaries. Into the tubular lumen, and sodium will be absorbed by the cell and ultimately transferred to the capillaries. So what is understood by it? If the kidneys would become dysfunctional, if renal perfusion will reduce, body's ability to generate bicarbonates will be compromised. Similarly, body's ability to keep potassium into control will also be compromised. So the simple result is reduction in bicarbonates, increase in potassium. And also if the kidneys are dysfunctional, sodium conservation also gets compromised. Sodium may reduce. Therefore, a simple test that we do in even at district level or smaller places to detect whether there is a pre-renal problem or a renal problem in a borderline case, where you cannot be sure whether the kidneys have been knocked out or acute tubular necrosis have started. What test you will do? Urea is a function of volume of the circulating blood. If the circulating volume gets compromised, then urea will increase. As long as kidneys are functioning very well, creatinine will remain normal. And as soon as kidneys function will get compromised, creatinine will also rise. So what is dominating? If kidney dysfunction is dominating, then the ratio of urea to creatinine, which is 40:1, our urea, normal urea is 40, creatinine is around 1. So this ratio will be disturbed in favor of higher urea in pre-renal problems, or when the patient is dehydrated, it will be disturbed in favor of higher creatinine if kidneys have developed acute tubular necrosis out of dehydration, fluid deficiency, water deficiency. So these are very, very simple things, but even before that happens, that is what I want to emphasize, bicarbonates get reduced if kidneys become dysfunctional. So the reduction in bicarbonates in ABG probably is the earliest indicator of impending acute tubular necrosis. जब मुश्किल होती है कि पता नहीं किडनी काम कर रही है कि नहीं कर रही, परफ्यूजन तो ठीक चल रहा है, फ्लूइड तो ठीक है, फ्लूइड और नहीं दे सकते, वाटर डेफिशिएंसी we are not sure, and you are or if the patient is under cardiologist care, either or, the cardiologists do not like lot of fluids to be given to the patients, right? So you have to balance, and the simplest confidence that you can give to the cardiologist is, look, his bicarbonates are getting compromised, they are reducing from 24, they have come to 20, 18, 16, something like that. Now the second thing, which is the measurement of sodium, is done vis-a-vis FeNA, fractional excretion sodium, FeNA. तो जब सोडियम reabsorb नहीं होगा, conserve नहीं होगा, and it will be thrown into urine, what is going to happen? The patient, that means the patient is into renal problem. Acute tubular necrosis, two things will happen. Creatinine will rise, sodium will reduce. And therefore, when these two things will happen, the normal sodium serum is about 140 and creatinine is about 1. This ratio will be disturbed and creatinine is high in urine and sodium is low. Therefore, urinary sodium will rise and urinary creatinine will reduce. So, the ratio of urinary sodium to serum sodium, to make it safe, दोनों को मिला के करेंगे तो सारी जो गलतियां हैं वो न्यूट्रलाइज हो जाएंगी. टू urinary creatinine to serum creatinine, this ratio is normally 1. सबको काट दिया तो हमने सब 1 हो गया. And if ratio rises in favor of lower sodium, then it will also go in favor of higher creatinine. So, kidney acts very, very fast, responds very, very fast. So, the earliest changes of destabilization take place in kidneys, which are eminently reflected in ABG. इसलिए मैं आपको emphasize करना चाहता था, जब कभी भी कोई patient आपके पास आए, आपको लगे कि यार इसकी किडनी काम कर रही है कि नहीं कर रही, कोई किडनी में तो प्रॉब्लम नहीं, you do an ABG, your bicarbonates if they are normal, your PENA is normal, probably your kidneys are still safe. Otherwise, no, this is again very elegant diagram though, but now acid base is managed in at two places. Kidneys, this is called metabolic location of acid base balance, and these are lungs which are respiratory location of acid base balance maintenance. So what is going to happen? लंग्स का काम है CO2 निकालना और किडनी का काम मैं बता चुका हूँ आपको. व्हाट किडनी डू आई हैव एक्सप्लेन टू यू. लंग्स स्टिमुलेट वेंटिलेशन. Ventilation would mean both depth of respiration and rate of respiration, and when both increase, ventilation increases and CO2 is reduced. जब CO2 reduce हो जाएगा तो क्या होगा? Probably I should have put some slides earlier, which are put later. CO2 represents acid in ABG. Actual acid in the body is calculated by hydrogen ions, but in ABG hydrogen is represented by carbon dioxide. Alkali in ABG is represented by bicarbonates. In plasma also it is represented by bicarbonates. So this is a small difference. So when there is a metabolic acidosis, lungs do little bit of harder work and they remove CO2 to compensate for what is going on at the kidney level in terms of creation of acidosis. So there are several centers. So I am just confining to two places, two locations in the body. One is kidney, where I have tried to explain to you, and another location is lungs. Now you have host of information in ABG, function of lungs and kidneys, because I have explained to you क्या क्या होता है उसमें. lungs CO2 के साथ खेलता है और kidneys bicarbonates के साथ खेलती है. So functions of lungs and kidneys: tissue perfusion status, electrolyte at a glance, lactate, blood sugar, hemoglobin and hydration status. आप सीरियल सैंपल देखिए एबीजी के और उसका फ्लूइड बंद कर दीजिए. सुबह उसका हेमेटोक्रिट आएगा 33 और आपने दिन भर फ्लूइड नहीं दिया, आप शाम को उसका एबीजी करिए, हेमेटोक्रिट विल राइज टू 39. दैट मीन्स ड्यूरिंग द डे पेशेंट हैज नॉट रिसीव्ड. आपको नर्स कितना ही बोलता रहे, रेजिडेंट कितना ही बोलता रहे, सब जा रहा है, ठीक है, 100 ml पर आवर जा रहा है. व्हेन यू एग्जामिन एबीजी, बट यदि आपको लगता है कि सीरियस है, सिंसियर है आपका रेजिडेंट नर्स, एक बार फिर कर लीजिए एबीजी, बिकॉज इट टेक्स 1 minute. आपको पता चल जाएगा व्हाट इज गोइंग ऑन. Anion gap, I will come to that. Ionic calcium levels, and if there is hypoxia, whether it is FiO2, ऑक्सीजन कम जा रही है उसको बाहर से, या VQ मिसमैच है. VQ मिसमैच होता है वेंटिलेशन परफ्यूजन. V stands for ventilation, Q stands for perfusion. तो लंग ठीक काम कर रहा है या सर्कुलेशन में कोई प्रॉब्लम है, तो दोनों का जो रेशियो है उससे पता चल जाता है हमको. एंड इसमें जो एल्वेलर और आर्टीरियल ग्रेडियंट होता है, that also plays an important role, but I will skip that. Now talking about acid base imbalance a little bit. For normal function of the body, having said that, body tolerates acid much more than alkaline pH. Body easy diabetic इसके patient 0.8. But if the patient is obtunded and has COPD, and despite taking treatment, if he is obtunded, that means his CO2 has gone up to 40, pH will be brought down to 6.9 or 7.9. These patients also will, despite obtundation, they will survive well. If, however, if their pH because of hyperventilation, रेस्पिरेटरी रेट 40 हो गई, दौड़ के आएगा और वो दौड़ता रहेगा, या इन अदर टर्म्स बॉडी दौड़ती रहेगी, लंग्स दौड़ते रहेंगे और CO2 रिड्यूस हो जाएगा एंड pH गोज अप टू 7.5 प्लस. These patients they decompensate very fast because acids are always in excess of alkalis, right? I am going faster, Shitu. I can understand. Both acid base levels are maintained in two sources. It comes from food and metabolic production. However, acid production and net always exceeds base. Therefore, balance of this excess acid has to be eliminated or excreted or neutralized by some internal mechanism of the body itself, which is mostly by lung, or you have to do something from outside. Now, this is seldom done. Why I have put this particular slide? Those who do ABG can watch, I can watch. It is seldom done and it should be done 100%. And the incidence of complications because of not doing Allen's test and non-existent collateral circulation in palm leads to 1 in 50,000 case problems, and that is a very high incidence because आपने करना ही नहीं था वहाँ, यही तो करना था और क्या, और आपने वहाँ पे एक needle डाल दी और patient goes into peripheral cyanosis and sometimes even into necrosis of the palm. This test must be performed before taking AG cell. Cleanse the fist, apply pressure on the radial and ulnar nerve artery. दोनों को क्लींच करके पाम की ब्लेंचिंग हो जाएगी. अल्नर नर्व को हटा दीजिए, रेडियल नर्व को देखिए, आपका सब कुछ ठीक हो गया, इसका मतलब कोलेटरल सर्कुलेशन हो गया. फिर एक बार अल्नर रेडियल नर्व को दबा के रख लीजिए, अल्नर नर्व को देख लीजिए. तो दोनों कोलेटरल सर्कुलेशन यदि ठीक है तो फिर देन प्रोबेबली you are puncturing at the right location. Now, preparation of the syringe is also very, very important. I strongly recommend all these syringes should be pre-heparinized, and you leave minimum margin or no margin for error if it is pre-heparinized. What we do, we always either take excess of heparin solution or suck some air. In the process, we suck some heparin, draw heparin up to 2 cc mark, throw it away, it leaves about 0.0025 cc. But whatever heparin that coats the syringe surfaces through its length and width, it makes the syringe prone to absorption of calcium and potassium. Therefore, always they are depicted lower in ABG. Therefore, don't react to lower potassium and calcium levels very fast in the ABG. So, wait for the actual electrolyte calculation from the lab, report from the lab. Therefore, expel very well air from the syringe, rotate syringe in hands to mix heparin to avoid microclots, which are very, very fast to take place. Record FiO2 patient is receiving, transfer the analyzer or place of sample ice if delay is more than 5 minutes. This again seldom done. पड़ा रहता है कई बार सैंपल भूल जाते हैं. So it otherwise gets denatured, corrupted, and it will get coagulated. Always discard the first few drops because on the tip of the syringe it will always has got the tendency to clot. So acid in extracellular fluid is reflected by H ions. However, in ABG it is represented by carbon dioxide. CO2 level is maintained by lungs, whereas bicarbonates is maintained by kidneys. Maintenance of this is mainly performed by renal system, as I already discussed. I will skip acid base disorder because time is running out and it requires lot of leisurely discussion. बहुत आराम से acid base disorders को आराम से discuss करना होता है. And these are information, and I tell you every single information value that you get in ABG report is important from some or the other point of view. In the very first report you can know about the prospective work that you are needed to do in every patient that arrives in ABG. If you have a level of lactate 15 plus, then you have a job at your hand. That means the patient's prognosis is already guarded. So interpretation of ABG takes you to 3 stages, stage 1, 2, 3, and first CO2 and ABG, you just look कि ABG किधर, pH किधर जा रही है. What we are concerned with is pH and PO2 level, or in other terms, if the patient is on oxygen, PF ratio. As long as pH is somewhere between 7.3 to 7.4, there is no major cause for concern. As long as the PF means what you P stands for what you see as oxygen level in the ABG, PO2. F is what oxygen you are providing, 60%, 80% or 100%. So if this ratio is more than 200, again there is no major cause for concern. So again it will give you lot of clue. And there are lots of rules and ways and means to move forward in interpretation of ABG. There are rules of compensation. But what is more important, if you think that your ABG report is not matching the clinical diagnosis that you are trying to make, or the clinical inference that you have drawn after examining the patient. Many times ABG analysis will go away, but there is a standard table. उसके अंदर होता है कि pH कितना है तो हाइड्रोजन कितना होना चाहिए बॉडी का, or hydrogen is calculated by this formula. So it takes about 30 to 40 seconds to do that, and your hydrogen calculation comes like this. This pH is 7.30, and by calculation in this particular patient pH should be 7.55. The patient is alkaline, badly alkaline, and his respiratory rate is he's offended, and he needs ventilation because of.
Sir, last 1 minute, sir.
Right. So I will skip anion gap. Anion gap is very important. It is calculated as sodium minus sum of chloride and bicarbonate. This is very important, and if anion gap, which is normally is around 15, if it is high, gives you clue to diagnosis of several things. Similarly, there is a delta gap, which if is higher, then gives you information that there is a possibility of another acid base disturbance in addition to what you apparently see in the ABG analysis pH wise when the patient is not responding. There is a term known as permissive hypercapnia which we use during ventilation of the patient suffering from ARDS, because we do low tidal volume ventilation, allow CO2 to go high as to allow pH to fall up to 7.20. We do not bother about the CO2 levels. What we take care of is we don't allow pH to fall below 7.2. So there were a number of cases which I had planned to discuss with you, but there is paucity of time. So I will stop at that. And पहली प्रेजेंटेशन में ही बहुत डिले नहीं होना चाहिए, इसलिए I will. No, this is a very interesting topic. As I said, this is mathematics, this is science, this is philosophy, this is art, and for some people it is even passion to discuss acid-base imbalance. When we were students, acid-base वाला पन्ना आते ही फटाफट पढ़ लिया, तो 5 सेकंड में पढ़ लिया. Same with electrolytes, and as we become clinicians, particularly related to intensive care, emergency care, how important these issues are that you come to realize, and it's a quite fascinating field of medicine. Thank you
sir.
so much.
Thank
Is there
you,
any
sir.
questions?
Definitely, ABG is the most important and crucial test as far as the monitoring in ICU is concerned regarding the critical patient. And sir, you have provided the basic insight of the ABG test, what we should know about the basics of ABG. Any questions from the audience side? Thank you, sir. Thank you, sir. Now we proceed to our second lecture, ABC of ECG. For this, I would like to invite Dr. Pawan Mehta.
That was a very informative talk. Thank you very much, sir. The next talk for the day, as sir mentioned, is ABC of ECG, practical tips for emergency and treatment. Dr. Pawan Mehta will be talking about this topic. Dr. Pawan Mehta is a senior intervention cardiologist at Rajasthan Hospital. He specializes in angiography and angioplasty via the radial route. Apart from heart attack management, he also has expertise in pacemaker, ICD, CRT implantation and device closure of atrial septal defects. I now invite sir to the stage.
Good afternoon, respected seniors and dear friends. I will present ABC of electrocardiography. ECG is the procedure of recording the electrical activity of the heart. The electrode combination records the potential difference at two sides from the body. The characteristic shape and timing of the ECG wave are due to the spread of wave of depolarization and repolarization associated with each heartbeat. In 1901, Sir William Ephoven in Netherlands demonstrated the mechanism of ECG, and in 1924 received Nobel Prize for this. Till then, ECG is the most commonly used cardiovascular laboratory procedure. So, the impulse arises in the SA node, and from the SA node, the impulse traverses to the AV node through internodal fibers and depolarizes the atria. The electrical activity goes rapidly to the AV node via internodal pathways. Then the depolarization spreads more slowly across atria, and the conduction flows through AV node. From AV node, the depolarization moves through the ventricular conduction system to the apex of the heart, and from the apex it depolarizes upwards and depolarizes the left ventricle. This is the ECG paper. It has small squares and large squares. The vertical shows voltage and the horizontal axis demonstrates time. So each small square is 1 millimeter in width and height. Each small square is 1 millimeter and it shows 0.04 second in width and 0.1 millivolts in height. Each large square is 5 millimeter in width and 0.5 millivolts in height. The standard speed for recording ECG is 25 mm per second. At this speed, 5 large squares are present in 1 second. So, STT segment demonstrates ventricular repolarization, and the QT interval is the duration of ventricular activation and recovery. The QT interval depends on the heart rate, and when the heart rate is high, we can detect the corrected QT by the Bézard's formula, that is the QT to QT divided by under root of RR interval. The atria begins to contract about 25 milliseconds after the start of the P wave, and the ventricles begins to contract shortly after the peak of the R wave. The QT interval is the time required for the ventricles to undergo a single cycle of depolarization and repolarization. So this is the demonstration of how the electrodes generate instantaneous potential developed on the surface of the cardiac muscle mass. And the representation of the electrical activity of the heart is critically dependent on the position of the electrode. The same electrical activity will look different on different electrode combinations. A combination of electrodes for recording a lead is called a lead. We have 12 standard leads for ECG, 6 limb leads and 6 chest leads. So in lead 1, the positive electrode is kept at the left arm and negative electrode is kept at the right arm. In lead 2, the positive electrode is kept at the left leg and the negative at the right arm. And in lead 3, the positive electrode is kept at the left leg and negative at the left arm. And this constitutes an arbitrary triangle, which is called as Beethoven triangle. These are the unipolar limb leads, and we have this augmented limb leads, which have AVR, AVL, and AVF. The augmented limb leads have 1.5 potential of the unipolar leads. We have color coding for the electrodes. So the electrode should be placed at the proper position. For the right arm, it is color coded as red, left arm yellow, left leg green, and right leg is black. The right lower limb is neutral electrode. Similarly, the chest lead should be placed properly. The V1 should be placed at the 4th intercostal space with right external edge, V2 at the 4th intercostal space with left external edge, V4 at the apex or the 5th interclavicular space as mid-clavicular line, V3 between V2 and V4, V5 at the same level with anterior-axillary line, and V6 at the same level with mid-axillary line. The leads look at the heart in the coronal plane. So the 1 and the AVL leads look at the heart at the lateral surface of the heart. Second, third AVF leads shows inferior portion of the heart, and the AVR or V1 shows the right side of the heart. Similarly, V1 and V2 looks at the anterior of the heart and the right ventricle. The V3 and V4 shows anterior and septal part of the heart, and V5 and V6 shows lateral and left ventricle. While interpreting an ECG, we must check the name on the ECG, the time and date, and what is the indication for the ECG, whether it was done for routine pre-op procedure or routinely or because of chest pain. We should compare it with the previous ECG or subsequent ECGs. We should look at the calibration of the ECG paper, whether the ECG machine is properly calibrated or not. We should look at the rate, rhythm, axis, and other elements of the ECG. So the ECG should be properly calibrated, that is 10 mm equal to 1 millivolt, and the ECG paper should be 25 mm per second. So this is the normal axis of the heart is around towards the lead 2, that is almost around 50 to 60 degree. And the normal axis is minus 30 to plus 90. If the axis is towards minus 30 to minus 90, it is considered as left axis. and 90 to 100 is right axis. If it is between 90 to 180 is extreme right. Or how to calculate the heart rate? If the heart rate is regular, we calculate the heart rate by dividing the number of large squares by 300 or number of square squares by 1500. If the heart rate is irregular, then we count the number of cardiac cycles or RR interval in 6 seconds and multiply it by 10. So suppose in the first ECG, the number of large squares are 3 between 2 RR intervals, so the heart rate is around 100. Similarly, in the this ECG, the 4 large squares are present, so the heart rate is around 75. We should look at the rhythm, whether it is regular or irregular. The normal heart rate is around 60 to 100 in adult patients. Apart from this, if the rhythm is unstable, we have to see for the signs of low cardiac output, whether there is systolic hypotension, excessive heart rate less than 40 or more than 150. Are the limb leads are set up correctly? Are the chest leads are set up correctly? Because in AVR, in normal hearts, the AVR is always negative and lead 1 is always positive, and there is R wave progression is there. So this is a ECG in which the limb lead reversal is there. The AVR is showing a positive R wave and limb leads are showing negative. So the limb lead reversal is there. Apart from this, we have to see whether any artifacts are present or not in the ECG. So this is an artifact because the QRS morphology is not proper. So it is an artifact. There may be electrical interference also present while doing the ECG. This is an electrical interference. The normal PR interval is less than 120 to 200 milliseconds. If the PR interval is less, there may be associated delta wave may be present in WPW syndrome. So there may be congenital accessory pathways which showed slurring of the QRS complex and white QRS. This is an ECG of a WPW syndrome where there is short PR interval with slurring of the QRS complex with delta waves. So there may be. This is an ECG with first degree heart block. The PR interval is prolonged. The PR interval is more than 200 milliseconds. This is an ECG of Mobitz type 1 of Vankebeck phenomena in which the PR interval progresses until a P wave is missed. This is type 1 Mobitz or Vankebeck phenomena. The upper one is a type 2 Mobitz type 2 heart degree block in which the PR interval is constant but a P wave is missed. So this is the P, this is QRS, this is P, this is QRS, and these P waves are missed. In type 3 or complete heart block, there is complete AV dissociation. The P wave comes of its own and the QRS complex comes of its own. They have different heart rates. The Q wave is pathological if it is deeper than more than 2 small squares, if it is wider than 1 small square. A small Q wave can be normal in lead 1, 2nd, 3rd, AVL, V5 to V6. That is because of the septal depolarization. So this is a QS complex which is abnormal. This is a deep Q wave is present. The PR segment elevation or depression in patients with myocardial infarction indicates concomitant atrial ischemia or infarction, and it is associated with poor outcomes. The QRS height. If there is LVH, then the R wave in the V5, V6 is very high, and the S wave in V1 and V2 is very deep. There are several criteria for LVH. For example, Cornell criteria, modified Cornell criteria, but this is the most important in which if the S wave in V1 plus the R wave in V5 or V6 which is more than 35, then LVH is present. There may be secondary STT changes present any LVH. This is the strain pattern. Similarly, in RVH, right ventricular hypertrophy, the common findings are the dominant R wave in V1, which is more than 7 millimeter, and the S wave is more than 7 millimeter in V5 and V6. So this is the RVB in which the R wave is prominent in V1 and right-sided chest leads. In LAHB, the left anterior fascicle is blocked. The usual ECG finding is left axis deviation with small r and capital S in 2nd, 3rd AVF and small q and capital R in 1 and AVL. In left posterior fascicular hemiblock, it has reciprocal changes with LAHB. It has right axis deviation with small r and capital S in 1 and AVL and QR in 2nd, 3rd AVF. It is associated with poor prognosis because left posterior fascicular block is quite uncommon and it is associated with massive myocardial infarction. In LBB, we have seen M pattern or RS R dash in V5, V6 and similarly W pattern in V1. This is the ECG of LBBB. So we have RS R dash in left-sided chest leads, and this pattern in V1. In RBBB, we have seen opposite. So this is RS R dash pattern in right-sided chest lead and deep S in V6. This is the RBB. This is an ECG of the right bundle branch block. The normal QT interval ranges from 0.35 to 0.5 seconds, and it normally varies according to age, gender, and heart rate. As the heart rate increases, the QT interval decreases. So to detect the correct QT interval, Bézard's formula should be used, and this is an ECG of an inferior MI in which ST segment elevation is there. Apart from this, we can also see the reciprocal changes present in the precaudal chest leads. This is an ECG of a patient with atrial fibrillation. We have fibrillatory waves present. This is the normal P wave, and in atrial fibrillation, the fibrillatory waves are present. It can be associated with fast ventricular rate or slow ventricular rate. ECG of a patient. There is irregular heart rate is there, though the QRS complex is narrow because AV conduction is normal. If it is associated with WPW syndrome, then QRS complex may be wide. In atrial flutter, there is sawtooth shaped flutter waves present with heart rate of 250 to 350. So the first ECG is atrial fibrillation, the second ECG is atrial flutter. There may be variable conduction block in patients with atrial flutter. So this is an ECG of a patient with atrial flutter. It has variable AV conduction, and there is sawtooth waves present in V1. The normal pacemaker rate is 60 to 100. Suppose if the SA node fails to generate an impulse, then junctional rhythm can be present with normal QRS with the rate of 40 to 60. And if the ventricular escape rhythm should be present, it has wide QRS with heart rate of 15 to 40. Sinus arrhythmia is a benign rhythm. It is usually associated with respiratory respiration. It usually varies with respiration, and the heart rate increases with inspiration and decreases with expiration. It is a normal phenomena. So, should I stop? Ventricular dysrhythmia can be present with ventricular premature ectopic beats, or this is a ventricular. Ventricular dysrhythmia can be present with ectopic beats. If it is a single ectopic beat, if two ectopics are present, then it can be couplets or triplets. If it is more than 3 ventricular ectopics are present, it is called as ventricular tachycardia. The ventricular tachycardia can be sustained or non-sustained. If the ventricular tachycardia persists for more than 30 seconds, or if the patient is hemodynamically unstable, it is sustained. And it can be slow or fast VT. If the heart rate is less than 160, it is slow. If it's more than 160 to 240, it is fast ventricular tachycardia. This is an ECG of a patient's ventricular tachycardia. While looking at the ECG, we can also find out the origin of the ventricular tachycardia. Suppose if the RBB morphology is there, it is rising from the left ventricle. If we're looking at the axis, we can demonstrate from what part of the right ventricle it is arising. So, ventricular flutter, it has a heart rate of 250 to 300. So this is a patient. This is an ECG of a patient with ventricular flutter. This is a patient with ventricular fibrillation. It has bizarre, distorted QRS morphology. So it is a last 1 minute, please. This is a Torsades repointers with. It is present with abnormal prolongation of the QT interval, and along with electrolyte imbalance, there is twisting and turning of the QRS complex, and is usually associated with congenital or acquired QT prolongation and electrolyte imbalance. So this is a right P pulmonale. There is prominent tall P wave is present in patients, respiratory patients associated with COPD. This is P mitral, where the width of the P wave is more. In V1, we can demonstrate this negative deflection. Hypothermia, in hypothermia there is prominent J waves, it is also called Osborne waves. Hypokalemia, we can see there is prominent U waves are there. Apart from this, we have low amplitude T waves. In hyperkalemia, there is prominent T waves, and QRS complex is wide, and when the potassium level increases, there is complete heart block and the P wave disappears. So ST segment elevation is associated with subepicardial injury, whereas ST segment depression is associated with subendocardial injury. Last, treat the patient, not the paper. Electrical activity triggers mechanical activity. If there is no electrical activity, no mechanical activity. But electrical activity does not guarantee mechanical activity. The more cells are involved, the larger the deflection of the ECG. If the wave of the electrical activity is moving toward the electrode, the wave will be positive. If the wave is moving from the electrode, the wave will be negative. Thank you.
Thank you very much, Dr. Pawan Mehta for your nice presentation. And now, any query from the audience? Thank you.
The next talk will be presented by Dr. Ravindra Singh Rao. It will be ABC of 2D Echo, Practical Tips for Clinical Correlation. Dr. Ravindra Singh Rao is an structural cardiologist who specializes in complex angioplasty, TAVI, TMVR, Mitra clip, rota ablator and shockwave angioplasty from Mount Sinai Hospital, New York and Washington University of Medicine, St. Louis, USA. Sir is also a visiting consultant at Lilavati Hospital, Mumbai. I now invite Sir to stage, please.
Thank you, Anupriya, for the kind introduction. Good afternoon and welcome you all. And respected chairpersons, Dr. Ajit Singh sir, who was more of a friend than a teacher. Our association goes back to 2006. Dr. Bharat Bhushan Sharma sir, who was also my assistant professor when I was doing my MD 2006. So I'm really glad and happy to see both of them here. I will not waste any further time, and that was a very comprehensive talk which was given by Dr. Pawan Mehta and sir as well. But one thing which was lacking was the participation from the audience. We would like this symposium to be a two-way communication, and then only it can be a successful. Otherwise, we are just talking like parrots, and we don't get the feedback. So from now on, I want more participation from the audience, that you should ask the questions which you feel, which you face in your clinical practice. You must be seeing thousands of patients, and I'm sure there might be certain clinical scenario. Probably, if we give an input, it can be helpful. And on the other hand, we can also learn from you that what are the challenges which are faced in our clinical practice. So ABCs of 2D Echo, Practical Tips for Clinical Correlation. Case summary. 26-year-old male patient, fracture femur, orthopedic surgery, bedridden for past 3 weeks with cast in place. Developed sudden onset shortness of breath, blood pressure is 100/70, ECG suggestive of sinus tachycardia, slight cough, no fever, saturation is 92%. Any guesses? Fat embolism, okay. Any more guesses? Pulmonary embolism, okay. Sepsis? Acute MI? Anybody for acute MI? Okay, I see one acute MI also. So I think we had two scenarios here, fat embolism and pulmonary embolism. So fat embolism would be more appropriate if it happens during the surgery. So fat embolism is usually seen when the surgeon operates, puts a cast, mobilizes, and within 24 hours. But here is a scenario which is after 3 weeks, and it is most likely pulmonary embolism, and this is most commonly missed. So you are practicing, you see this patient in your OPD. What do you suspect? Rightly said, you suspect pulmonary embolism. So sorry, I didn't give you the options. Aspiration, hyperventilation, MI, pulmonary embolism. So I think pulmonary embolism is what we are suspecting. So what are the relevant investigations which will help in clinching the diagnosis? 2D echo. Any other test which you can think of? CTPA. Okay, you are sitting at a periphery where there is no CTPA and there is no 2D echo machine. D-dimer, perfect. So you get a D-dimer done, and it's a very useful test. You don't have these investigation, D-dimer, your clinical suspicion, treat. You suspect that the echo report, the echo doctor has reported as normal, because a lot of radiologists and physicians are also doing 2D echo. I don't undermine their clinical skills. I think they are doing their best. But still, you should, if you have a strong suspicion, what do you look in 2D echocardiogram? Anybody? RV dilatation. Perfect. And most important, along with RV dilatation, is IVC collapsibility. Okay, I mean, maybe IVC dilatation, I can take that. Septum protrudes into the left ventricle. Very good. But what is the reason for that? Pulmonary hypertension. Very, very important. RV dilatation with increased PA pressure is highly suggestive of pulmonary embolism. So what are we looking on echo? You see RA-RV enlarged. Now you get an echo pic. How do you know that RA-RV are enlarged? Do you need to remember any numbers? Any guesses? You just compare with the LALV. Don't do anything. The echo report will have the pictures on it. Look at the RA-RV. If the RA-RV are bigger than LALV, they are enlarged. You don't have to think of any numbers. And this is a picture which is, as soon as the clot goes to the picture, the RA-RV starts enlarging. So RA-RV enlargement is a sign of pulmonary embolism in such patient, moderate to severe tricuspid regurgitation with moderate to severe pulmonary hypertension. So I'm not going to go into the treatment part because it's going to be covered in a different lecture. So take home message, suspect pulmonary embolism, look at the pictures, RA-RV enlarged and pulmonary hypertension. 33-year-old female patient, nursing staff, history of low-grade fever, weight loss, loss of appetite, hematology is normal, urine routine is normal. What hematological test would you be interested in this patient? Any test? ESR, you guys, so fever, low-grade fever, a hospital employee, female patient, you suspect tuberculosis in this patient. What radiological test would you be interested? Chest X-ray. Okay, let me show you the chest X-ray now. Okay, diagnosis. Cardiomegaly. Okay, that's good. What next would you order now? You would order a 2D echocardiogram, right? So what do you think is being shown in this 2D echo? Any guesses? Because the reason I've selected these pictures is that we handle these cases day to day in our practice. So you should know how to look at the pictures. Fantastic. Who said that? You have to enroll yourself for the iPad quiz. It's a real iPad. Yes, so you see that pericardial effusion. And what is the difference between these two pictures on the left and the right? What is happening? Anybody? It's very simple. You see, the heart is dancing in the fluid.
Is it called dancing heart?
Okay. Okay, the heart is done. But important thing, you look at the chambers. Again, I want you to understand the chambers, nothing else. So next time you are not fooled by the reports and you want to see the pictures. So on the left side is RA-RV, on the right side is LALV. But if you see the right atrium, see there is a collapse of the right atrium. See right there? But one gross difference between two pictures is on the left side it is mild pericardial effusion, on the right side it is massive pericardial effusion. Left side patient you can empirically treat with ATT. You need not even refer this patient to us. But right side patient is a patient who is suffering from cardiac tamponade. So I want you to understand the sign of a cardiac tamponade. You see the picture, massive pericardial effusion, hypotension. Sometimes these patients actually don't have hypotension. They have like baseline 90s and 100, but they have sinus tachycardia. So that is called right atrial collapse. So cardiac tamponade, we all know about Beck's stride, low blood pressure, distension of jugular veins and muffled heart sounds. And this is because an acute tamponade is a medical emergency. because we are focusing on the echo talk only, so you should look at the pericardial space and the amount of fluid which is in the pericardial space. Okay, so next, third case scenario. So we learned about pulmonary embolism, we learned how to appreciate RA-RV enlargement and pulmonary hypertension, we learned about pericardial effusion and cardiac tamponade. 42-year-old, because sometimes this echo reporting the pericardial effusion is missed, but when you look at the picture from now on, you can challenge the cardiologist who is sending the reports and you can get a better picture. 42-year-old male presented with gradual onset progressive shortness of breath for past 2 months. Now he has dyspnea in doing daily activities and also has PND, paroxysmal nocturnal dyspnea. At present, he has swelling of feet, abdominal distension, and engorged neck veins. Hematology and ECG are normal. Significant past history of unknown viral infection 3 months ago. Differential diagnosis. Okay, so we have myocarditis. Sorry? Cytomegalovirus. Yes, so what I'm trying to stress here is this patient had a history of viral infection 3 months ago. Now this patient is in your OPD. He presents with shortness of breath, dyspnea, daily activities, and also focus on the PND. Now he has paroxysmal nocturnal dyspnea. And so at present, he has swelling of feet, abdominal distension, and engorged neck veins. So I want you to understand 2 important symptoms here. There is a symptom of left heart failure. There is a symptom of right heart failure. Very important. So now the history of viral infection in the past. So what is this patient suffering from? Good. So you already diagnosed myocarditis, pericarditis. So the next investigation is 2D echo. Okay, let's see what the 2D echo shows. Very important. The diagnosis is dilated cardiomyopathy, which is involving both LV, RV, and all 4 chambers. The etiology in this particular scenario is most likely post-viral. So again, you can look at the pictures and you see how all 4 chambers are enlarged. So the 2D echo report, you should look at these things. Global hypokinesia, all 4 chambers dilated, moderate MR, moderate TR, ejection fraction. Now tell me one thing which is missing in this report which will help you to optimize your medical management. What do you want to give this patient? Any particular drug which will help his symptoms to be better? Diuretics, right? So what is missing? What is missing in this report? IVC size, very important. Look at the IVC size and its respiratory variation. That will tell you whether the patient is volume overloaded or volume depleted. So ask your cardiologist, ask your radiologist, when you're writing 2D echo report for such patient, mention, please review the IVC size and reports its respiratory variation. That will make you even more smart and you can manage your patients better. So we already saw another important thing which was missing in this patient is assessment of RV function. We are always focusing on the LV function, but you should also know about the RV function. And how do we assess? We look at the TAPSE. So this is, you don't have to memorize it, but TAPSE is a finding for RV function. So in your echo report, you can write, please comment on IVC size and the RV function, because that's how the management and the prognosis can change. Okay, one more case scenario. So we learned about pulmonary embolism, we learned about pericardial effusion, we learned about dilated cardiomyopathies. 22-year-old male patient presented with transient LOC, loss of consciousness. He complained of palpitation prior to episode, history of sudden cardiac death in the family at young age. What investigation would you like to get it? What do you suspect? Acute MI? How many acute MI? Okay, so let me show you the ECG. Dr. Pawan had taken a great class on ECG. Diagnosis. So you says, okay, hypertrophic? So that's very important, hypertrophic obstructive cardiomyopathy. And the reason is you will be seeing these patients in clinical scenario. But the history is very important. Sudden death in the family under the age of 40 years, shortness of breath. Now you order a 2D echo. So whenever you write any investigation, you should have differential diagnosis in your mind. You don't write investigation just for the sake of writing. So when the reports come back, okay, this is what I suspected and this is what has been reported. So Clinical examination, systolic murmur in the left lower parasternal region, no murmur radiation to the carotid. This is very important. You put your stent and then you see a systolic murmur. Would you label as aortic stenosis? No. Then you have to look at the carotids and you do certain maneuvers. I'm not going to bore with that, but this is how echo looks like. Septal hypertrophy, systolic anterior wall motion abnormality, mitral regurgitation, and diastolic dysfunction. So I'm not going to go into detail, but again, you look at the pictures. That's what we are taking this class for. We're not, we don't want you to, have a full knowledge of echo, but we want you to have a relevant knowledge of echo. So you look at the septum. Look at the septum is so thick, and these patients also have mitral regurgitation. Diagnosis, HOCM. But once you diagnose HOCM, then you know how to treat this patient. You'd get beta blocker, calcium channel blockers, alcohol septal ablation, AICD. Most importantly, you do family screening. Case summary, 66-year-old female patient, diabetic, obesity, osteoarthritis, presented with dyspnea on exertion for past 2 years. Progressive, clinical examination normal except for bilateral pedal edema, PFT normal, chest X-ray normal, hematology normal. Very common scenario, सांस फूल रहा है, सांस फूल रहा है, सांस फूल रहा है. So many elderly patients you see in your clinical practice. What next investigation? Okay, we have one diagnosis of heart failure. Somebody from the last row. वो जो mask पहने हुए सर से. You have to participate. This is not a one-way communication. We want you to participate. So, anybody, sir? आप जो AC के पास बैठे हुए सर. What next? कोई भी investigation बोलोगे, that is relevant. Whatever you feel like. Even ECG is relevant. Chest X-ray is relevant. Okay, so let's go ahead. So you get a 2D echo report. That is what we are doing most commonly, right? Even before a chest X-ray ECG, we are ordering a 2D echo for such patient. Normal chamber size, normal valves, normal LV and RV systolic function, ejection fraction 60%, normal pericardium, IVC 20 mm with less than 50% respiratory variation. So what is missing in this patient? So this echo report looks normal to you, right? Is this patient suffering from heart failure? Anybody? Okay, how many think that this patient is suffering from heart failure? Okay, sir also heart failure. Heart failure. Okay. Respiratory cause. Okay, respiratory cause. We label sometimes these patients as hysterical. Okay. So this patient, what is missing in this patient is something called diastolic dysfunction. Very important. A normal echo report does not mean that this patient does not have a heart failure. So this is called heart failure with preserved ejection fraction. So what do you ask your echocardiographer or a cardiologist? To report the diastolic functions. Very important. So once you have a diastolic function, you know this patient is suffering from diastolic heart failure. So again, you don't have to mug up this whole slide, very busy, but there is something called E upon E prime, which can be reported on echo, and that indicates the LA pressure. LA pressure indicates the pulmonary capillary wedge pressure. It indicates the pulmonary artery diastolic pressure. So in your prescription, you can write 2D echo for LV function, diastolic function, and LA pressure assessment. That will put a lot of pressure on us. Then we know that our colleague is going to treat this patient rightly. So diastolic heart failure has equal mortality equivalent to a systolic heart failure. These patients suffer a lot. What is the treatment? You treat the risk factors. Avoid tobacco, limit alcohol, track your blood pressure, exercise, reduce stress. So there is no treatment as such for diastolic heart failure, but you treat the underlying cause. I have 4 more minutes. Coronary artery disease. I'm not going to bore you. Yes, sir. Yes, sir. All those, whatever risk factor modifications. So that studies are coming up. The latest study has come up, but in my practice, I don't use that for normal EF. Maybe a mid-range EF, something between 40 to 50% I can use, but not. Coronary artery disease. So what is the importance of coronary artery disease? We come across a lot of patients who would say the echo is normal, the ECG is normal, and we still advise them angiogram. So the echo and ECG are abnormal only in presence of something like a non-ST elevation MI or a ST elevation MI, which will affect certain wall motion abnormality. So for coronary artery disease, you suspect You see for wall motion abnormality. Next, you see for ejection fraction. Sometimes what you can see is you have a patient in your clinic, anterior wall MI, you have thrombolized that patient. Patient is absolutely fine, stable. Next day you go to the ICU to take rounds. All of a sudden you notice that patient is tachycardic. His heart rate is in 130, 140. Blood pressure is borderline, around 90. What do you suspect? You suspect a mechanical complication of an MI. You suspect a ventricular septal rupture, you suspect a free wall rupture, you suspect a severe mitral regurgitation. And that is when the 2D echo is important. So I'm not going to bore you with the coronary artery disease 2D echo. Everybody knows about it, but you should know when to order a 2D echo in a patient who has CAD. Echo for syncope. How many of you order 2D echo for syncope patients? So again, I'm just going to come to the last slide. You diagnose the syncope. Is it a cardiac syncope? Is it a non-cardiac syncope? Uncertain syncope. So for all practical purposes, again, if I'm going to summarize, if you suspect that this patient, if in your opinion you don't find an obvious reason for a syncope, get a 2D echo done. Valvular heart disease, very simple. Again, I'm not going to go into detail because the report itself will tell you mild, moderate, severe mitral, aortic, or whatever valve disease. Thank you very much for your kind attention. Now 2 minutes are for question and answer. Alcohol septal ablation is a procedure which we do for patients who suffer from hypertrophic obstructive cardiomyopathy. So there are two treatments. One is myomectomy, where we would go by doing an open heart surgery, resect that part of interventricular septum. But what we do in intervention cardiology is we identify a septal artery which supplies to that part of the septum. We inject alcohol, and next 3 months' time, that muscle regresses. So it is called alcohol septal ablation. No, we do these procedures a lot. We are a referral center for this. We have had patients traveling from all across for alcohol septal ablation.
Yeah, thank you very much, Dr. Ravindra Rao. But I have a question. So as you mentioned nicely that many of times it's not mentioned that the diastolic dysfunction is there or not. But what we frequently see is that type 1 diastolic dysfunction. Many of the times in all the echo report we get it written. So how seriously we need to take type 1, or at what level we need to do the intervention for the diastolic dysfunction? Because I don't know, I have become a tendency that type 1 diastolic, so it's kind of written in most of the reports, and we many of times don't bother about it as a pulmonologist. So if you can highlight some important aspect about the diastolic dysfunction.
That's a very good question, because even patients ask me, what is this grade 1 LVDD? This is written sometimes in the report. So that's why I wanted to stress on it. First thing is you need to have a clinical correlation. Grade 1 left ventricular diastolic dysfunction is not a clinical finding. It's more of an echo finding where we calculate E upon A. So there's something, I'm not going to go into detail. But then if you suspect that this patient is dyspneic, you need to ask for a E upon E prime. We need to assess. It's our fault. We need to give you an LV end diastolic pressure which will correlate with the left atrial pressure, which will correlate with the pulmonary capillary wedge pressure. So to answer your question, grade 1 left ventricular diastolic dysfunction in an asymptomatic patient does not mean anything. As we all age, the ventricle becomes stiff and it does not relaxes equivalent to a young patient. So this is called diastolic dysfunction. It refers to a condition where the ventricle is stiff. So how the ventricle works, there's something called lucitropy. So ventricle has to relax, the blood comes into the LV, and then the LV pumps. So when the ventricle does not relaxes, the amount of blood which comes to the LV is less, so the amount of blood which LV pumps is also less. So this is called diastolic dysfunction. There is no medicine as such for diastolic dysfunction. You treat the underlying cause, treat the hypertension, exercise, lose some weight, treat diabetes, quit smoking, lead a healthy lifestyle. So grade 1 LV diastolic dysfunction does not mean anything.
Yeah, thank you very much. I have one more question. Many times we read the reports. We as a pulmonologist read the echo reports, so we are not doing the echo. So what we see with the patients with acute MI and with the heart failure, with low ejection fraction, many times we read the mention of clots in the LV what does that mean, and how do you take as a cardiologist if it's mentioned that clot is present in any of the ventricle?
So again, that's a very good question. So that tells me that madam looks at the echo report seriously. So that's very important. We need to look at all those investigations very clearly. So if it shows LV apical clot, we would put these patients on acetylene or warfarin for 3 months until the clot gets endothelized. But most common reason for an LV apical clot in our cardiology is acute MI. But even in the respiratory conditions like hypereosinophilic syndrome, very commonly biventricular clots are seen. So if you're seeing a patient where you suspect hypereosinophilic syndrome, get a 2D echo done.
Thank you very much. Any questions from the audience?
Or else we will ask the questions. Thank you so much.
Really nice session. We enjoyed it so much.
Thank you very much, sir. That was a very, very interesting talk. Thank you, respected chairpersons, for sparing time on this hot summer afternoon. I would now like to invite our chairpersons for the next session. Dr. Chand Bhandari, ma'am. Dr. D.K. Jain, sir. Dr. Lakshmikant Goyal, sir. Thank you very much. The next talk will be delivered by Dr. Sheetu Singh. The topic is Approach to the Patient with Sudden Onset Shortness of Breath, Cardiac versus Pulmonary. Dr. Sheetu Singh is a nationally renowned pulmonologist with a keen interest in ILD and intervention pulmonology. She has gained experience as visiting fellow at Cleveland Clinic, USA. She was a former associate professor at SMS Medical College. She has an impressive array of national and international research publications. An avid teacher and academician, she is popular among patients, colleagues, and students. I now invite ma'am to the stage, please.
Am I audible? Can't. I think I have to stick to this. Is it working? Yes, now it is. So with the respected chairpersons, I would like to begin. So welcome all of you to RHL, and it gives me great joy, especially because my teachers here like Dr. Chand Bhandari, Dr. Bharat Bhushan Sharma, Dr. Ajit Singh are here. And it is, I think, no less than a blessing to be here. A topic that I have today is, very fundamental and basic. And I would beg your pardon if it gets too basic. But I think to discover certain investigations, I think it is better to start from the basics. A 35-year-old female, obese, with COPD, and heart failure presents to you in the emergency room. Patient is dyspneic, respiratory rate is 40, the saturation is 95. What all things come to your mind? Is her lung full of fluid, or is it full of pus? Is it a pneumonia, or is it a pulmonary edema? Or has she have aspirated something? We really don't know. So, the clue to this is back to the basics. I think every one of us has read this manual of Hutchison, whom we have all adored. What is dyspnea? Dyspnea is a subjective experience of uncomfortable breathing, a symptom that can be the cardiac, pulmonary, or neurological. It is caused due to increased drive to breathe, increased work of breathing, and stimulation of receptors of the heart, lung, and vasculature. Assessment begins with determining the quality and intensity of the discomfort. I think let's take a pause from all this gibberish. Everyone who all have watched this detective series. Which one is this? Okay. So I think we all have to put on our detective hats and become Byomkesh Bakshis whenever we have to find out the diagnosis. Pick up innocuous looking clues, something that may not be relevant for the patient, but it is of relevance to you as a doctor. So what to ask? So I can see few of my residents also sitting here, and they know how relevant it is, and they have to ask it in their clinical examination. To start with, it is the onset. So the acute onset is seen in pneumothorax, MI, pulmonary embolism, aortic aneurysm. Subacute in exacerbation of all underlying lung diseases such as COPD, asthma, ILD, heart failure. Chronic is all the chronic lung disease, the cardiac diseases. The second is the progress. How is it? Is it intermittent? Is it progressive? So anything intermittent, that is the patient is getting better. So something like an acute asthma, between there are episodes, and in between the patient is totally healthy. Certain psychogenic or hyperventilation syndrome episodes can also be intermittent. Progressive in COPD, heart failure. Certain aggravating factors such as food can help you to pick up aspiration. Exertional dyspnea can be seen in cardiac, interstitial lung disease, pulmonary vascular disorders. Relief in the form of rest can be another of these. A seasonal pattern is often seen in asthma and COPD with seasonal infections. Diurnal variation in asthma, heart failure. Orthopnea is very classical of cardiac failure, and another important differential is diaphragmatic palsy. Associated factors are also important because wheezing, rhinitis, family history of asthma is suggestive of asthma and allergy. Hemoptysis may be seen in tuberculosis, in malignancy, pulmonary edema in heart conditions. Travel history is irrelevant, particularly in cases of, why do you ask for travel history? COVID. So pulmonary embolism also, long travel history, patient developed a DVT and the clot then migrated. Tobacco use. What are the diseases associated with tobacco, I think? COPD, IPF, CA. Occupational exposures like silicosis. Then we have the Monday morning fever, that is occupational asthma. So a history is paramount with the age, smoking history, duration of the breathlessness, severity of breathlessness, and all the ancillary symptoms such as sputum, hemoptysis, wheezing, chest pain, palpitations, tiredness, weight loss, anxiety. Past medical history is very important, and so is the family history. Examination, you start with the basics, the pulse. Just put a hand on the pulse and assess the regularity, the respiratory rate, blood pressure, oxygenation. How is the patient? Is the patient obese? Can it be obesity, hypoventilation? The PEFR it's a very easy tool and underrated. No one does it, but it helps you assess, especially in the ER. You give a peak flow meter. If you know the patient has a peak flow more than 250, it can sometimes rule out respiratory cause. Chest auscultation. Sometimes, we get so much dependent on these investigations that we forget to use our stethoscope. Heart sounds and pulmonary edema. A head to toe general physical examination is important because sometimes a simple examination can reveal pallor, and you can, you don't need to go for the big round of tests. Investigations, I will be coming to it in a short bit. So the ancillary test, the very basic is the chest radiograph, which is the primary imaging tool. Low radiation can assess consolidation, effusions, pneumothoraces, And cons are the low sensitivity to detect small pneumonias. So this is a 10-year-old cough, breathlessness, fever since 8 days. Who's going to tell me? What do you see here? Consolidation. There's a classical sign here. Do I have a pointer here? So what you see here is a bulging fissure seen in Klebsiella pneumonia. The second X-ray, what do you think? Left upper lobe cavity. So 40-year-old cough, breathlessness, fever since 2 months. Your most important differential would be pulmonary tuberculosis. 58-year-old cough, breathlessness since 2 years. What do you see here? Hyperinflation. So seen in COPD and emphysema. So this one is another 45-year-old female, breathless since 2 days. 2 days back she travelled 12 hours on a bus. And what is this sign called as? So, you know, just like a camel has a hump. So this is the Hampton's hump, which shows a pulmonary infarction, triangular wedge-shaped opacity with the periphery, the base towards the periphery and the apex towards the center. 40-year-old male, breathlessness in 8 days. What do you see here? A hydropneumothorax because there is a air fluid level. And what do you see here? 56 male, chest pain, breathlessness since 1 day, pneumothorax. So sometimes it is difficult to differentiate between bulla and pneumothorax. So at that time always look at the collapsed lung margin. It is important. So if you are not able to see that margin, it is most likely a bulla. But if you see that, it is seen in pneumothorax. And in this particular patient, what do you see? Right or left? So bilateral pleural effusion. And if you look very carefully, you can see some sternal sutures also here. So just by this X-ray, you can come to know that this patient may be in heart failure and probably with the past history of CABG. The next important underrated test but now getting popular is ultrasound because it has no radiation exposure, fast, reproducible, can be done on the bedside. However, low sensitivity in acute dyspnea, requires some skill to interpret the bedside images. Patient factors such as subcutaneous air, body habitus may cause a difficulty in interpretation. The other important tests are BNP and CBC. Let's see how it helps. So this is a 60-year-old male with history of COPD, heart failure. He is in respiratory distress with audible wheeze and tripoding. Diaphoretic, hypertensive, pitting edema to his knees. They have given albuterol, no response. What do you see on the ultrasound chest? Very classical. So what you see here is some lines that are coming from the pointer till here. These are called the B lines, and these are classically seen in whenever you have fluid in the interstitium. So when you have these, you look at certain things like this: a raised JVP, S3 gallop, crepitations, pedal edema. You go ahead with a pro-BNP, which will take some time. So an ultrasound put at that time will immediately give you a clue that this can be heart failure. You order these particular set of tests and you clinch the diagnosis. Other important and useful tests are D-dimer, serum test, easily done. The cons are that it requires risk assessment and clear clinical question because it can be falsely positive in an array of other diagnoses such as infection, malignancy, trauma. In COVID, I think everyone was getting a D-dimer. Ventilation perfusion scan is another set which is important for patients of pulmonary embolism, and I will come to it here. So this is a 56-year-old female with sudden onset of shortness of breath, pulse is 115, saturation 88, blood pressure is 110/60. The chest examination reveals crepitations, traveled by car to a hill station recently. So what is your differential diagnosis at this point? So we had a similar case just now. We have pulmonary embolism as one of the important differentials. Why? Because the pulse is raised. So the most common, in fact, ECG abnormality in a pulmonary embolism is sinus tachycardia. So it is not S1, Q3, T3. It is more specific, but the most common is a tachycardia. You have a patient with tachycardia, saturation is borderline, BP is borderline, and she has a travel history. You get a D dimer which is raised, and you get a CTPA done, which is a gold standard test. So what you see here is clots here. A ventilation perfusion scan can be done at this point. However, there are limited centers actually doing it. So what you see here is the ventilation is good, but the perfusion, there is a defect. That means that there is a chance of embolism. Other investigations, ABG, we've had a wonderful talk by Dr. Runta, and I think I don't need to elaborate on that more. CT scan, again sensitive, specific, but can cause contrast nephropathy if you are using an IV contrast. So this was a recent male, 61 male, breathlessness and fever since 7 days, saturation was low. The ABG shows a type 1 respiratory failure. The X-ray was here, and on CT scan you see ground glass in the peribronchovascular region and the subpleural region. So what kind of pneumonia do you suspect here? Is it bacterial? Is it viral? What do you think? Viral, very good. So what you see here is the atypical viral pneumonia with ground glassing in the peribronchovascular and the subpleural region. The H1N1 throat swab was positive. This patient is actually getting discharged today from us. Another clue, so this is for the audio-visual round. For those of you who stay here till tomorrow, we have this wonderful quiz. A 24-year-old male with shortness of breath, follow-up case of diabetes mellitus type 2. What is the ABG showing? What acidosis? Metabolic. What type of breathing is this? Very good. So you have to be, the eyes can only see things that the mind knows. So train your mind, you have to be knowing things to detecting them in your OPD and the ERs. So this is classical Kussmaul breathing. The blood sugars were for 550, the urine ketones were positive, and the patient was diagnosed as diabetic ketoacidosis. ECG, I think, has been elaborated, and I'm running short of time. So this was a patient, 56 male with shortness of breath and ghabrat. What you can see, Dr. Pawan has already elaborated. ST elevation and a raised top T. So I think I will sum it up here. So do you have any questions? So everything is crystal clear. Thank you.
Thank you, Dr. Shitu, for a nice talk, and you are always clear in your lectures. Any questions from audience side? And message is that dyspnea is not only because of the pulmonary cause or cardiac cause. There are many times there is multifactorial causes. So always assess one and more cause if required. Thank you, Dr. Shitu. Proceed to the next speaker.
Thank you very much, ma'am, for a very useful talk. The next topic for the day is dealing with post-COVID complications. It will be delivered by Dr. Madhur Joshi. Dr. Madhur Joshi is a consultant in the Department of Pulmonary Medicine, RHL. Dr. Joshi has experience of almost 10 years and specializes in intervention pulmonology and sleep medicine, airway diseases, and has a special interest in pulmonary rehabilitation, drug-resistant tuberculosis, lung cancer, infections related to lungs. I now invite Sir to the stage to please deliver his talk.
Yes. Yes, sir. Next slide is ECCO. Next is
A very warm good afternoon, in fact, a hot good afternoon to everybody. I'm Dr. Madhur Joshi, consultant pulmonologist with Rajasthan Hospital. Honorable chairpersons, so today I'll be speaking something as what we all have been facing since last couple of years. First, initially, it was dealing with diagnosis of COVID and then post-COVID complications. So, the objectives of my next 15 or so minutes will be to recognize acute and long COVID cases, how to identify deteriorating symptoms early, especially in post-COVID patients, post-COVID complications and organ involvement with case scenarios presenting to a pulmonologist. We had a variety of cases that presented to us. It was a multidisciplinary approach in managing all of them, be it cardiology, gastroenterology, nephrology, or neuropsychiatry. So just to begin with, COVID, now we know, we have all seen acute COVID cases. Now, COVID cases, at the end of 4 weeks, we divide them in ongoing symptomatic COVID and post-COVID syndrome, which is also called as long COVID. So with sign and symptoms of 4 to 12 weeks, we consider them as ongoing symptomatic COVID patients or a post-COVID patient which has got symptoms of 12 weeks or more. So complications can occur at any stage, be it in acute COVID or be it in long COVID. These are a myriad of symptoms, a bit crowded slide, where we all know acute breathlessness, hypoxemia, chest pain, ongoing dry cough, breathlessness, fever, palpitations, significant sputum production, hemoptysis, may it be hypotension, that these COVID patients are presenting to us in a post-COVID era. So coming on to the cardiac complications, we need to look for fatigue, dyspnea, chest pain, and palpitations as symptoms. Most of the patients, 20 to 30% admitted patients, they had cardiac involvement. There was ischemia, thromboembolism, heart failure, arrhythmias. The most common mechanism was direct cardiomyocyte damage or damage secondary to hypoxia, microvascular dysfunction, thrombosis, and cytokine storm. So just a flow chart, how to see a patient who has presented with acute coronary syndrome, especially when the patient is post-COVID or when he is admitted with COVID. We need to identify the troponin levels, pro-BNPs. We need to look for ECGs, and we have the standard protocol once we have diagnosed a patient of having any acute coronary syndrome, may it be STEMI or non-STEMI. As far as GI complications are concerned, we need to look for symptoms like ageusia, lack of appetite, nausea, vomiting, dyspepsia, diarrhea, abdominal pain, hepatitis. The mechanism being the presence of angiotensin converting enzyme to receptors which are present in epithelium of GI tract and facilitates the entry and replication of the virus in the GI system. It may be drug-induced. The risk factors for GI complications are severe disease, elderly age, admission to intensive care, respiratory tract infection, gut dysbiosis, liver injury due to COVID-19, drugs, and polypharmacy. So as far as symptoms are concerned, we need to look into the liver function test. The most common being we need to identify the patients, those who have developed liver or GI symptoms during or in the post-COVID status, or they already had underlying liver dysfunction. So we need to identify the liver enzymes, which is usually less than 5 times in an acute COVID-induced hepatitis. It may be more than 5 times if it is drug-induced. We have commonly used remdesivir as an antiviral in these patients, so that was Other than remdesivir, there are many other drugs which can cause hepatotoxicity. Again, dyspepsia, diarrhea, abdominal pain are the various symptoms that we need to look for and do a workup. Renal complications, we need to look for hypertension, pre-existing illnesses, CKD or diabetes mellitus. So a new onset hypertension in these patients should alert us, and we need to do a workup for their renal functions. They are acute kidney injury, they may be a CKD, there may be glomerular diseases, there may be hypertension. Well, 90% of the cases of hypertension are primary, but 10% of the cases, they are secondary hypertension. We also need to look into the excretion of albumin and proteins. Signs and symptoms we all know, starting from anorexia, headache, generalized anasarca, reduced urine output. We need to work up thorough with the new hypertension or worsening of hypertensive patients. The investigations we all know, we need to do a renal function test and an ultrasound abdomen. As far as neurological complications are concerned, well, again, the SARS-CoV-2 has a high affinity for human angiotensin converting enzyme 2 receptor, which is also expressed in neurons and glial cells. The mechanism may be non-immunological or immunological, and we have a myriad of diagnoses as far as neuropathophysiology is concerned. We have Guillain-Barré syndrome, we have parenchymal manifestations like encephalitis, seizures, etc. Cerebrovascular manifestations may include hemorrhagic stroke, ischemic stroke. Meningeal manifestations have meningitis, persistent headache, transverse myelitis, and various other spinal cord manifestations, cranial nerve manifestations. So coming on to respiratory complications, we all know that lungs bears the maximum burden of direct viral damage. Post-COVID syndrome, as far as NIH UK is concerned, they have defined them as a persistent symptom and sign beyond 12 weeks without any other alternate explanation. A long COVID or a post-COVID patient is a symptoms recurring beyond 4 weeks of onset, and a post-COVID complications are present in post-COVID fibrosis to infections and thrombotic events as well. So just a myriad of signs and symptoms what you have to look for. We all know that cough, distressing cough and worsening dyspnea are the presenting symptoms. We need to look for the clinical findings, and we need to look for oxygen saturations, 6-minute walk test, chest radiographs, and CT scans if required. So coming on to some cases that we have encountered and we have been dealing with. So this was a 42-year-old male without any comorbidities. COVID onset was a month back, recovered within a week. He was never admitted, took symptomatic treatment without any steroids. His maximum CT score, which was done at that time, was 8 out of 25, now presented with fever of 7 days duration. He was being treated as typhoid before he was referred to us. To our surprise, he had a family history of CKD in 2 of his siblings. When he presented to us, his TLC was normal, his creatinine was 1.5. He had a raised dimers, and his chest X-ray showed a right lower zone homogeneous opacity. We did an ultrasonography just to look more into his CKD status. There was a relatively small left kidney with normal sonomorphology. This was a CT scan. So can anybody elaborate the CT scan? Okay, so options, does it look like a bacterial pneumonia, a tubercular pneumonia, a fungal pneumonia, or a mass? So people with tubercular pneumonia can raise their hands. Nobody. Fungal pneumonia can raise their hands. Is it a mass? Okay, so we have a few going with mass. So this was a fungal cavity, suspected fungal cavity, which was reported on CT scan. We did since the D-dimers were raised, we did a CTPA as well. So there was associated thrombosis as well. So this was the report. There was a segmental thrombus in laterobasal subsegmental branch of right lower lobe artery adjacent to the cavitatory area. So we further would like to work upon it. So we did a bronchoscopy and biopsy. Yes, initially sputum was done, but which was all negative. So we did a bronchoscopy and biopsy. So this is what we got. So there was a non-septate hype with 90-degree angle branching and non-parallel walls. So the crux here is the non-septate hype. On histopathology, it was diagnosed as a case of pulmonary mucormycosis. Well, the bile fluid also showed the possibility of mucormycosis because on staining, they had this non-septate hype. The fungal culture was positive for mucormycosis. We could also get the sensitivity report with it. So our diagnosis was a post-COVID pulmonary mucormycosis with pulmonary thrombosis, embolism, and diabetes mellitus with a history of familial CKD. This was his CT scan after a month of antifungals and other supportive treatment. Another case, 33-year-old female, COVID onset 1 month back, referred with respiratory failure, severe sepsis, bed sore, abdominal wall abscess. She had no comorbidities, but her BMI was 36. She was on high flow mask with 15 liters. She was maintaining 80%, tachypnic, unable to move the extremities, altered sensorium. Although she was hemodynamically stable, with reasonably good organ functions, but her chest X-ray had shown bilateral diffuse infiltrates. We did a CT scan again. So there were a few organizing pneumonia that was seen along with the consolidation in lower lobes. This was her CT scan during her path of recovery. We did it again. She also had an abdominal wall abscess. Well, our surgical colleagues, Dr. Sharad Daga, he did a great debridement. To our surprise, when the biopsy was sent to the lab, it again was suggestive of mucormycosis in abdominal wall abscess. So again, non-septate fungal hyphae. You get this mucormycosis report maybe in a day or two, but on staining, if you are seeing non-septate fungal hyphae, you should alert yourself. So again, treated with antibiotics, antifungal, weaned off from oxygen support, and she was enrolled for pulmonary rehabilitation. Another interesting case, 56 male, COVID onset 3 months back, twice intubated for COVID ARDS with pneumomediastinum, had seizures and infarct during his stay. He was tracheostomized and discharged with a hospital stay of 45 days. Now again presented with pain abdomen. He was diagnosed as a case of GB perforation and abscess, which was initially percutaneously drained but ultimately had to undergo laparotomy. Post-laparotomy, he landed up with septic shock, ARDS, again tracheostomized, recovered and discharged walking. This was a CT scan during his COVID. Can you see that? Pneumomediastinum. So again, the CT score was 23 out of 25 with the pneumomediastinum. This was his USG report. So he had this pericholestatic collection, which was initially drained. It was pus. The biopsy that was post-laparotomy, it showed chronic calculus cholecystitis. This was the diagnosis. So he was post-laparotomy for GB perforation and abscess with peritonitis, septic shock, respiratory failure requiring mechanical ventilation and tracheostomy. Another case, 66-year male, referred from elsewhere in respiratory failure. He had a history of COVID onset 2 months back, now febrile illness and desaturation, diabetic, on insulin. His chest X-ray again showed same bilateral diffuse infiltrates with cavitation in left upper lobe. So again, the previous one was also with cavitation, again one more with cavitation. So can anybody guess what it is? Definitely, it is, we cannot guess, but does it look like a bacterial cavity, a necrotizing cavity, or a tubercular cavity, or a fungal cavity, or a malignant cavity? So we did sputum initially, which was negative, but we have to do a bronchoscopy. So bronchoscopy showed acid-fast bacilli in this patient. We did a thorough workup for fungal again. So galactomannan in bile fluid was negative. The PCR of bile fluid was again negative. Fungal culture was again negative. We were very confident. We started the patient on antitubercular treatment. To our surprise on culture, it was negative for Mycobacterium tuberculosis, but it was positive for non-tubercular mycobacteria. So again, we treated accordingly and enrolled the patient on pulmonary rehabilitation. He was discharged on room air and all oral medicines. 31-year-old male without any comorbidities but a BMI of 38. COVID onset 1 month back, managed with high flow nasal cannula, awake proning. He also developed pneumomediastinum and pulmonary embolism. This was his CT scan. You can see pneumomediastinum. So he was thrombolized then tapered off to on oral anticoagulants, weaned off from oxygen support, pulmonary rehabilitation, discharge home on room air. One more case with right pleural effusion. He was found to have exudative high AD effusion, started on ATT. Another good patient, this was 67 female with a score of 23. She had raised D dimers. She had right lower limb DVT. Her venography was also suggestive of deep vein thrombosis. She also had pulmonary embolism. So again, on low molecular weight heparin, which was followed by newer oral anticoagulants, weaned off from oxygen, pulmonary rehabilitation, still following up in OPD from Assam with good functional status. So just to summarize, what was common in all these patients? Yes, they all had COVID. They are still surviving without any limitations. It was a multidisciplinary approach and teamwork that we succeeded in making them stay healthy. Pulmonary rehabilitation is not only physiotherapy, but a psychological support, nutritional support, along with physiotherapy. Just to end, this is a slide easily available on Google. This I have taken from European Respiratory Society. It divides your patient, any patient who is coming to your OPD in a post-COVID era, and you are suspecting post-COVID deterioration in symptoms. You need to look for these. You can categorize each one of them into 4 categories, basically 5. So 0 means nothing, none. There is no limitations. So you need to know how is the functional status. If a patient has got a good functional status, he will say that he can live alone without any assistance from any other person. And he is independently able to eat, walk, and do his routine activity. But any slight limitation, you need to work up for it, just to rule out any post-COVID complication. This is our team at Rajasthan Hospital. We are a pulmonologist, interventional radiologist, and our pulmonary rehabilitation team. Thank you. Any questions?
Post-COVID complication or long-term COVID or post-COVID syndrome should be taken care. हमें पेशेंट की किसी भी कंप्लेन को इग्नोर नहीं करना चाहिए. जैसा डॉक्टर जोशी ने बताया, पोस्ट-कोविड सिंड्रोम में जब कंप्लेन देखी, उसका एक्सरे देखा तो फंगल निमोनिया में दिखा, फंगल बोल भी निकली, उसके अंदर नॉन ट्यूबरकुलर बैक्टीरिया भी निकला, माइक्रोबैक्टीरिया बट नॉट ट्यूबरकुलर था. ट्यूबरकुलर बैक्टीरिया पल्मोनरी एम्बोलिज्म में निकली. तो कोविड के किसी भी पेशेंट को हमें छोड़ना नहीं है. लॉन्ग टर्म कोविड भी हो सकता है, पोस्ट कोविड सिंड्रोम भी हो सकता है. ऐसा नहीं है कि कोविड ठीक हो गया तो आपको कुछ नहीं हो सकता है आपको पोस्ट कोविड कॉम्प्लिकेशन हो रही है. इसी के साथ जैसा डॉक्टर जोशी ने बताया, कुछ चीज़ें समय के साथ ठीक होती हैं. इसकी गैस्ट्राइटिस है, इसकी एपेटाइट कम हो रही है, वो समय के साथ ठीक होगी. ये भी पेशेंट की काउंसलिंग का एक इम्पोर्टेंट है. हमें वीरेंद्र सर हमेशा कहते थे कि पेशेंट की किसी भी कंप्लेंट को इग्नोर मत करो और पेशेंट को काउंसलिंग जरूर. अगर पेशेंट का आप पे फेथ रहेगा तो पोस्ट कोविड कॉम्प्लिकेशन में भी वो आपके पास ही आएगा और वो ठीक भी होगा. थैंक यू सर, हमें ये सब सिखाया आपने. एंड थैंक यू डॉक्टर जोशी. नाउ हाउस इज ओपन फॉर एनी क्वेश्चन.
Let me congratulate for beautiful presentation. I have 2 points. One point, we right the day it started, 2000, December 2019, it was understood probably the respiratory disease may be having a high predilation for a bad outcome, but we turned out to be wrong. So in acute cases, what are the basic parameters of the patient behave very badly and some do not, number one. Number two, 2 days before there was an article in Times of India that after 2 years, every second patient who had a COVID suffering from non-COVID, post-COVID complications. So why it turned out to be so bad?
Sir, if you will see in most of the cases, even the cases that I presented, there was a common thing that was raised BMI. Patients of extreme of ages, patients with comorbidities like diabetes. If you have noted, the first case was a 42-year-old male. He was absolutely asymptomatic. Other than that, he had a history of CKD in 2 of his siblings. But before that, he was never being treated or never presented with any complaints to any doctor. So he developed, because he was having underlying CKD. So there was a subset of patients who were younger age group. There was a subset of patients without knowing any comorbidities that they already have. There was a subset of patients who were having raised BMI, and yes, then there were elderly patients as well.
One of the best answers was the first blood sugar level. If you find the high blood sugar level, he is going to give a bad outcome.
Yes, definitely, definitely. Thank you, sir. Any other questions, please? Thank you.
Indeed, the entire spectrum of post-COVID complications was covered very beautifully. I now invite Dr. Ravindra Singh Rao, sir, to talk about approach to acute MI, thrombolysis versus primary angioplasty.
Great lectures. One of the complications of post-COVID was acute MI. How many noticed increase in CAD patients in your clinical practice after post-COVID? Right. So we also came across a lot of patients who were young, healthy, and never had coronary artery disease, but one risk factor was post-COVID and post-vaccination. Some of them had post-vaccination also. Okay, so I'll go straight to the topic. Approach to acute MI, primary PCI versus thrombolysis. 90% of it is known by all of you. You all know that an ST elevation MI needs thrombolysis. So I'm just going to have some slides which will be like a revision slide. So we're going to talk about importance of time, treatment strategies and guidelines, STEMI network, fibrinolytic agent, and take-home points. This is my favorite slide. When you see a patient with acute MI, what do you do first in emergencies? You put him on oxygen, right? सबसे भागते पहले oxygen लगा देते हैं. Look at the guidelines. Oxygen is only indicated in patients with hypoxemia, anterior wall ST elevation MI, inferior wall MI. If your saturation is more than 90%, oxygen is doing harm. It is causing free radical injury. So first thing, if you have an acute MI patient, saturation is 95%, don't put him on oxygen. There is clear-cut guidelines only if the saturation is less than 90%. And look at the beautiful line. Routine oxygen is not recommended in patients with saturation of more than 90%. Class 3. You know what does that mean? Oxygen is doing harm. So you are harming the patient. So the instinctive, reflexive mechanism of putting the patient on oxygen is actually harming your patient. Class 3 indication. So take home message, routine oxygen use for a patient with acute MI presenting in emergency is causing harm. So look at the saturation less than 90%, then only you put this patient on oxygen. So we're going to talk about importance of time. All of you know about it. Management of acute MI and rationale for early reperfusion. Aim is to prevent death, limit the extent of myocardial damage, minimize patient discomfort and distress, re-establish the myocardial perfusion before irreversible damage can occur. There are two ways to re-establish the myocardial perfusion. One is mechanical, that is what we do, angioplasty. Second one is pharmacological, which you and me, we both do by a thrombolytic agent. And the third one is pharmaco-invasive, beautiful strategy, thrombolize the patients and do the rescue angioplasty. Because the most important thing in acute MI is time. Time is muscle. If this patient presents to any biggest center in the world after 24 hours, any center, nobody can save his muscle because muscle is already dead. And there is clear-cut evidence that in golden hours, if we treat the patients, the lives can be saved. This golden hour, if it is less than 1 hour, it is the best, but up till 3 hours. So this is just a slide which I'm going to discuss with you, and this is going to help us to actually understand what are the delays, where all the delays happen. So in this study, they had rural patients receiving thrombolysis in hospital, urban patients receiving thrombolysis in hospital, rural patients receiving pre-hospital thrombolysis. So look at the time. Call to on scene. So what does that mean? In our country, what we are talking about is door to needle or door to balloon. So that means patients present to us and then how fast we can give thrombolysis or how fast we can do angioplasty. But if you look at majority of time is wasted even before the patient comes to the hospital. So now there is a concept of total ischemia time from onset of pain. So if the pain has been there for 12 hours, even if he comes to me and I do the angioplasty in half an hour, I know I cannot save the muscle. So call onto the scene, that is where majority of time is lost. Then on the scene, patient reaches to you, but he's waiting in the OPD queue. There is a lot of time which is wasted in the ECG. There is a lot of time which is wasted in the interpretation. There is a lot of time which is wasted talking to the relatives. Then transfer, the lot of time which is wasted in the transfer, and also door to needle time. So I'm not going to go into these specific numbers, but when we practice, when we all of us practice this medicine or acute coronary artery patients, we can try to reduce this time. Now you get a call from your colleague, who is sitting, let us say, 200 kilometers away from you. There's a patient who's got a chest pain. You can ask him to do an ECG, send on WhatsApp. And then you can guide him that this patient is having an acute MI, thrombolyze him. So all those things, we will try to establish a network where we can help all the physician with an immediate diagnosis. You have a patient, you do an ECG, there is some abnormality, some doubt, send to us, we will help you to treat that patient better. Improving time to treatment, public education and acute MI awareness. You need to reduce symptom onset to call time. This is the most challenging thing. So patients don't come on time, and that's because they waste a lot of time just thinking that this is gastritis. Medical professionals, us also reduce the first medical contact to the treatment time. So STEMI networks, we are not there, but this is what we are thinking as an RHL hospital and RHL Heart Center. We need to develop STEMI networks with all the surrounding PHCs and CHCs and clinicians like you, so that patients who are having acute MI can be treated on time. And we also want to, last point, facilitate pre-hospital diagnosis and thrombolysis. So not all patients need to be referred for primary PCI. I'm going to come to that slide also. There's something called you do a thrombolysis before the patient comes for a primary PCI, stabilize the patient, and then refer for a rescue PCI or an elective PCI. So this pre-hospital diagnosis and thrombolysis is very important. So reperfusion treatment, there is mechanical reperfusion, primary PCI, pharmacological reperfusion, which is pre-hospital or in-hospital thrombolysis, pharmaco-invasive therapy, and I think in our country this is the best strategy. You thrombolyze the patient followed by an early angiography and mechanical intervention if needed. Time is critical for STEMI management. We talk about primary PCI. So primary PCI is the gold standard in STEMI care if performed within 120 minutes of first medical contact. So timely primary PCI is difficult to achieve, and this is very correct. Not all patients can reach to us or can be transferred to us within that 120 minutes. So what do we do in PCI? PCI, we go to the coronary artery, do an angiography, aspirate the thrombus, and then put a stent and optimize the angioplasty. STEMI treatment guidelines. Primary PCI is the gold standard for reperfusion treatment for STEMI if delivered less than 120 minutes of diagnosis. I'm going to stress this again and again. This is very important. Where this is not possible. Now let us say there's a lot of traffic and patient, or you are practicing at some remote place, and you calculate that if I transfer this patient to a hospital where an angioplasty can be done, but the transfer time is more than 2 hours. When this is not possible, fibrinolysis should be performed with a fibrin-specific agent. Tenecteplase, alteplase, or retiplase are advisable, but because of financial consideration in our country, we are using streptokinase in majority of patients, but we should offer, there might be a patient who can afford tenecteplase. So we should do fibrin-specific agent as soon as possible within 10 minutes from STEMI diagnosis. Again, this is very important. Now you see a patient is suffering from an anterior wall ST elevation MI. You don't talk to him about sending him for an angioplasty. You calculate how much time it will take for this patient to reach to a angioplasty center. More than 120 minutes, you thrombolize the patient with tenecteplase preferably. So this is a very beautiful slide from European Society of Cardiology STEMI Guidelines 2017 reperfusion strategy. Symptom onset early phase of STEMI is called less than 3 hours. Evolved STEMI is somewhere between 12 and recent STEMI is 48 hours. So you should know these terminologies: recent MI, evolved MI, early phase of STEMI, and symptom onset. So if you see within 3 hours, primary PCI is also class 1A indication. But the second point, fibrinolysis, even if you thrombolize the patient, it is a class 1 indication if PCI cannot be performed within 120 minutes. So this is very important. This 2-hour thing is very important. You are seeing a patient, an anterior wall MI. You refer that patient for an angioplasty and the ambulance is going to take more than 2 hours. Do not refer him. Thrombolize him. Because by the time he reaches to any hospital in the world, he is going to have a full-blown infarct. After 3 hours, okay, primary PCI, then you don't thrombolize. Now you send this patient for a primary PCI. Evolved, after 12 hours, don't thrombolize this patient. So 12 hours is not the time when the patient presented to you. This is the total ischemic time, the time when the symptoms started. So anybody presenting beyond 12 hours, primary PCI is the treatment of choice. So I'm going to again go to this slide. So you have a patient has a STEMI diagnosis on ECG. Now time to PCI center, less than 2 hours, transfer for angioplasty. Okay, more than 2 hours. Look at that, maximum 10-minute delay to administration, not more than that. If you can achieve these goals, the patient will benefit to the maximum. So if you are a high volume physician who is seeing a lot of coronary artery disease patient, maybe a nearby medical store can store a lot of these thrombolytic agents, or your hospital pharmacy can have a thrombolytic agent, or it could be tenecteplase, it could be streptokinase, but that 10-minute, maximum 10-minute delay to administration. And why tenecteplase? Because tenecteplase is a bolus fibrinolytic agent. Within 10 minutes you can give that injection. Streptokinase is an infusion. Reperfusion is successful, yes, you send the patient for a routine PCI. Reperfusion is not successful, you send this patient for a rescue PCI. So take home message is, if you have an acute MI patient and it takes more than 120 minutes for you to transfer the patient to a PCI capable center, thrombolize the patient. STEMI network, again this is, it's not yet there in our country. It is there in Tamil Nadu. They have established a beautiful STEMI network. Where what happens is that there is a hub and spoke model. Anybody who is having an acute MI, they would send the ECG to the main center. If it is a ST elevation MI, transfer time is more than 120. They advise the physician to thrombolize. Patient gets thrombolysis and gets transferred. This whole system is called STEMI India, which is being successfully practiced in Tamil Nadu. But these are the things: single emergency telephone number, protocols for standardized care, optimal pre-hospital care. Now we can thrombolize these patients in ambulance also. We need to have a defibrillator and a trained nursing staff. Bypass non-primary PCI capable hospitals to increase the proportion of patients receiving timely primary PCI. Cardiology intensive care specialists as a network leader. Involved healthcare authorities. This is very important because in our country, though patient is suffering from ST elevation MI, usko hamesha gas lagta hai. So we need to educate these patients, and that's where the healthcare comes into picture. Fibrinolytic agent. So this is, again, we're going to skip this slide, but this will be more relevant as we move forward and we try to teach these patients with pre-hospital thrombolysis. Thrombolytic agent, we have streptokinase, alteplase, reteplase, tenecteplase. Not all can afford tenecteplase, but whoever can afford tenecteplase, we should offer them. Otherwise, streptokinase also works very well. So this is again why we should use a bolus dose. This is the time of infusion. So you see tenecteplase has the shortest time where you can inject and the clot can be dissolved. This is the comparison between alteplase, reteplase and tenecteplase. Another important advantage of tenecteplase, it does not have immunogenicity. Plasma half-life is 20 minutes and it is very fibrin specific.
So ideal thrombolytic agent should be rapid acting, high efficacy in terms of both 60 to 90 minute vessel patency, low incidence of adverse events, low re-occlusion rate, easy to administer, simple patient-tailored dosage regimen, good long-term effects and cost-effective. So this is again a slide which clearly shows from 1995 to 2015 there is a significant decrease in mortality of patients suffering from ST elevation MI. Take home point, STEMI is a time critical medical emergency. Clinical output improves with reduced time to reperfusion. Every effort should be made to reduce ischemic time. This is very important. When you leave this hall and when you start practicing from Monday, you don't refer all acute MI patient. Very, very important. You calculate the time. More than 120 minutes, thrombolize the patient. Because by referring all acute MI patients, we are harming them. Implementation of STEMI network, we as an RHL, we will think of, we have to do this. We have to do this in future where we establish a STEMI network for our patients. Pharmacoinvasive strategy is recommended, and I'm going to stress on it. What is pharmacoinvasive? You do thrombolysis, patient comes to us, we do the PCI. And that's how we can save the myocardium. But primary PCI is considered gold standard if it can be performed less than 2 hours of first medical contact. So, to summarize, you see the strategies, the time starts clicking, you have a STEMI diagnosis, time to PCI less than 120 minutes, primary PCI, alert the primary PCI center. Again, you have to inform that center. We don't want to be activated once the patient lands in emergency, then we lose more time. More than 120 minutes, thrombolize the patient, then transfer to a PCI capable center, and then we do routine PCIs versus rescue PCIs. Thank you very much for your kind attention. Any questions?
Thank you very much for nice presentation. Any questions from audience?
What is the cost of this? Because we have been doing a lot of certain before. Recently we have done it. Stop doing it. How will the cost?
I think it's around 16,000, sir. But all these costs should come down. These are mainly for public strategy. The cost should come down. Government should do something because thrombolysis for an acute MI, it is life-saving. Otherwise, all these young patients with anterior wall MI, when they present very late to us, their EF is 25%. And you know, after that, they are always in heart failure. The first heart transplant is one of the indications for severe LV dysfunction post-MI, and that is commonly seen in our country because the average age of acute MI in India is 40. The average age of acute MI in Western world is 60. So late presenters, they have a lot of complications.
Very important message delivered. The basic question is you have said gas MI. So any specific question to be asked to the patient while a doctor is talking on phone, gas hai ya MI hai?
So that's a very good question. We all know how to differentiate between gas and MI, but the question which you can ask to the patient, ऐसी गैस जिंदगी में पहले बनी है? तब वो बोलता है जिंदगी में ऐसी गैस तो कभी नहीं बनी, तो हार्ट अटैक ही है. The most important, today I had a patient in the OPD, I'm a very educated family, classical angina, TMT positive, CT angiography shows 90% blockage. Done in Fortis and consider multiple. Still he comes to me for consultation and says, Sir, मुझे लगता है मुझे गैस ही है. Then I asked him this question, कि आपको ऐसी गैस जीवन में पहले कभी बनी? He said no. तो admit हो जाओ. He's already admitted. So the question which you can ask is कि ऐसी गैस अगर बनी है पहले तो हो सकता है गैस हो, but first time बनी है तो it is MI. Sorry, sir?
IV agents, they have a practice to give 300 mg aspirin, soluble aspirin, and 600 mg clopidogrel. So how would it be, along with the beta blocker, low dose?
So that's a very good question. So antiplatelet, acute MI, you load the patient with aspirin 325, clopidogrel 300 milligram, atorvastatin 80 milligram. At present, we would not give beta blockers. In the past, beta blockers was used in fact injectable 5 milligram every 5 minutes to the maximum dose of 15 milligram for all anterior wall MI patients. But studies have shown hypotension caused by acute MI and drugs equally have poor prognosis. So there should be an indication for beta blockers like good blood pressure, tachycardia. So during thrombolysis, I would avoid beta blockers. I would avoid any medicine which can cause hypotension.
Patient presenting with pain epigastrium, ECG is normal, and we have given pantoprazole and all, and still he's having the similar complaint. So there is a term called serial ECG monitoring. So basically, what is the time duration for that serial ECG monitoring, and till when we should do it?
So that's a very good question. Epigastric discomfort, normal ECG. So this is not ST elevation MI. One thing is for sure. ST elevation MI will clearly show you something on the ST elevation MI. Now you look at the whole clinical scenario. There is something called chance of having a coronary artery disease. It is called ASCVD risk factor. So you see whether your patient falls into a higher risk category versus a low risk category. A 25-year-old patient, no risk factors, probably he's in a low risk category. A 60-year-old diabetic, obese, hypertensive patient, probably in a high risk category. But you do clinical examination. One of the differential diagnoses for such a patient is actually cholecystitis or cholelithiasis. Both things have happened in the past. An acute MI patient have undergone a cholecystectomy and a cholelithiasis patient have undergone an angioplasty. This can happen. This is human error. But you should repeat ECGs every 10 minutes. But most importantly, you also do a clinical examination and an ultrasound and a troponin. And your further treatment will depend on whether the patient is at high risk of coronary artery disease, low risk of coronary artery disease. Even if you admit this patient for observation, it's all right if this patient falls into a high risk of coronary artery. But what we're going to start and what is being practiced in the world is something called a chest pain clinic. This patient presents to us in the emergency. We draw all the tests. We would do an immediate creatinine, and next to our emergency is the radiology department. We send this patient to a coronary CT angiogram. Coronary CT angiogram, we also look at the aortic dissection and pulmonary embolism. This is called triple phase testing. Normal patient goes home. So this is what can be used for an advanced patient where you are in doubt.
Patient is presenting with chest discomfort, ECG is normal. So we will go for a TROP-T, like we are in a periphery, we'll go for a TROP-T. So we should expect TROP-T to come positive after how much time?
6 hours.
6 hours.
6 hours. So TROP-T will, so again, your clinical suspicion, index of suspicion is very important. So such patients who is having chest pain, ECG normal, 1/3 patients can have that. So this, you first have to classify your patient. ST elevation, non-ST elevation, unstable angina. And that's how the treatment will follow. ST elevation MI is a deadly disease which you cannot miss. The treatment will be totally different. These two patients you can easily keep in your hospital, monitor and manage. But troponin start rising after 6 hours.
Sir, aortic dissecting patient can present with inferior wall MI. We have lying or not, and how you differentiate that? Is it due to thrombus or inferior?
Very, very good question. Inferior wall MI, aortic dissection. Very complex scenario. So how do you diagnose? Number one, you look at the history. So aortic dissection, what happens? The flap extends down to the coronary ostia, and one of the most common coronary ostia which is involved is right coronary artery, and these patients will have inferior wall MI. But look at the history. Aortic dissection patient will have sharp pain in the midline radiating to the back. Number one. Number two, history of hypertension. An ST elevation MI, inferior wall, blood pressure of 200, most likely aortic dissection. But the most important clinical finding is you palpate all the pulses. You palpate the right radial, left radial, right femoral, and maybe carotids. If there is discrepancy in the pulse, this is an aortic dissection. Because when the flap goes up, it also occludes the brachiocephalic trunk. Now, to summarize your scenario, if your patient, usually inferior wall MIs, if they are involving the RV, the blood pressure is low. Now, to summarize your point, if the blood pressure is high, young patient, marfanoid habitus, severe chest pain, like tearing chest pain radiating to the back, discrepancies in the pulse or the blood pressure, it's all same. You can measure blood pressure or the pulse. There is a high possibility that you are suspecting a dissection. Don't thrombolize this patient. So I'm going to summarize again. Inferior wall MI, even if you don't thrombolize, you are not losing anything, because RCA supplies maximum around 20% of the myocardium. So if you are in doubt, that's okay, but it can cause CHB, RVMI, cardiogenic shock, VSR, MR. But such a doubtful situation, don't thrombolize.
Thank you, sir.
Thank you very much.
Thank you. Thank you, Dr.
Thank you, Lakshmi.
Thank you very much, sir. Thank you, respected chairpersons, for your valuable time. There's a slight change. Before we take a coffee break, a brief introduction of the RHL Heart Lung Center will be given by Dr. Ravinder Singh Rao and Dr. Shitu Singh. I request ma'am and sir to please come to the stage.
Thank you, Anupriya. So, RHL Heart Center. The RHL Heart Center, our aim has been to provide a comprehensive care for all complex cardiac situations like cardiogenic shock, acute MI, angioplasties, valve replacements without open heart surgery, with a very experienced team of cardiologist, cardiac anesthetist, cardiac critical care specialist, critical care, pulmonary department, and multi-specialty department as our backup. So this is our team. That's me. That's Dr. Pavan Mehta, Dr. Prashant Varshney, and Dr. Govind Narayan Sharma, part of our cardiology team. And I'm going to share our journey for the 1 year when we started in February 2021 up till Jan 2022. Total cath lab procedures which we did was 1,406. We did 553 angiographies. We did 447 angioplasty, 65 rotablators, which is for calcified blockages, 22 IVL angioplasty, which is lithotripsy angioplasty. We did 63 TAVI, which is transcatheter aortic valve replacement, wherein we replaced the aortic valve without open heart surgery, which has been highest in the country. Mitra clip, where we repair the leaking mitral valve. Device closures for ASD, VSD, PDA, pacemaker, endovascular therapies for aortic aneurysm, intravascular ultrasound and OCT, which stands for optical coherence tomography, and Impella, which is the smallest heart pump used for patients with cardiogenic shock. But most important thing is outcomes. Here we stress on safety for our patient. We ensure a safe outcome in a complex situation. Our angioplasty intra-procedural mortality is 0%. Our in-hospital mortality is 0.6%. We lost only 3 patients out of 447, and these were the patients with cardiogenic shock, multi-organ failure, and multiple dysfunctions. This is our safe data, which is at par with the safest outcomes in the world. TAVI, our intra-procedure mortality is 0. Our in-hospital mortality is 0. We also published a paper on safety and procedural outcomes of intravascular lithotripsy in calcified coronary artery in Indian patients. This is the highest published data of lithotripsy angioplasty for calcified blockages in Indian Heart Journal. And we also shared our procedure outcomes. So our cardiac death in this paper is 0%. Our non-QMI was 2, which is 6.9%. Our QMI was 0. Hemodynamic instability post-procedure was 0. Bleeding complications 0, and arrhythmias was 0. I also did the first case of lithotripsy and TAVI in Lilavati Hospital, Mumbai, which was the first case in the country, which was also covered in media articles in Maharashtra. This year, we had patients who traveled from all across country for their cardiac treatment, as far as Dubai, Bangladesh, South India, and almost all states. We are the first center in the North India to start a robotic angioplasty program. Patients have traveled via air ambulance for TAVI and MitraClip. We also did the first case of MitraClip in India in a post-renal transplant patient. We successfully did Impella angioplasty for cardiogenic shock and acute MI with patients of LV ejection fraction, and this particular patient traveled from Jodhpur. This article was also covered by the magazine The Week. We did highest TAVI for 2022 as a single operator in the country. TAVI stands for transcatheter aortic valve implantation, where we can replace the aortic valve without surgery. Highest rotablator angioplasties for calcified coronary stenosis in the state with safe outcomes. But again, we would like to stress, the outcomes have to be safe, and for that, we need a comprehensive team. We also started robotic angioplasty, which is first in North India. The second was started by PGI Chandigarh after 2 weeks of our launch. The robotic angioplasty is safe, precise, useful for complex osteal lesions, decrease in the use of second stent, and decrease in the target lesion revascularization. We have an excellent cardiac surgery program which is being headed by Dr. Buddhaditya Chakravarti, one of the highest experienced cardiac surgeons from Harvard and Mayo Clinic. Total arterial bypass, redo valve surgery, MVR, AVR, and valve replacement, aortic surgeries, pental and hybrid surgery, MICS, and high-risk coronary artery bypass surgery. Our cardiac sciences is also backed by presence of ECMO machine and our critical care and pulmonary department as a backup. This is our team. Thank you very much for the kind attention.
Very good afternoon to all of you. I'm just a few minutes away from the coffee break, so I understand everyone is tired and exhausted. Pardon me if I sound pompous and pretentious, but my presentation is to highlight the work that we have been doing at RHL Lung Center. So we are a team, and I think without team, nothing is achievable, especially in medical sciences. So this is our team, and I think you've seen most of us here. So we have the able guidance of Dr. Virendra Singh, and on whose principles we are working on, of honesty, hard work. Even during, COVID, we were all physically taking rounds for all our patients, and I think we took inspiration from Dr. Virendra Singh. The team's most young and most, I think, enthusiastic person is Dr. Anupriya Agrawal. So in the hospital, if, a patient is struggling, the one person who will be at the side of the patient is Anupriya. So she's always there fighting with the patient and, for the patient. Dr. Madhur Joshi, he's one of the most dependable amongst all. He actually joined the hospital before even the first patient came in. So he knows everything in and out, and he can handle all the tough situations very compatibly. And I joined almost a year and a half back. I was previously working at SMS, and so the things that we are catering to at RHL Lung Center includes allergy, asthma, COPD, COVID, ILD, OSA, pleural diseases, respiratory failure, and interventional pulmonology. So in asthma, we have actually devised the asthmatic style to identify the trigger factors and teach the patient, counsel the patient. Sir has actually developed the Pink City Lung Exerciser, which is a very good innovation and helps the patient to exercise, especially the asthmatic patients. For severe asthma, these are those patients who have significant morbidity and mortality. And for them, we have the new kids on the block, that is thermoplasty, and the very, very effective biologics. So these are against the eosinophils or anti-IgE therapy and provides a lot of relief to the patients with severe asthma. For COPD, we have actually developed the pulmonary rehabilitation program, as Dr. Madhur had mentioned in his talk. Spirometry guided, a 6-minute walk guided program that caters to the patient, and this improves the exercise capacity and the quality of life, which is one thing that COPD patients often have a problem with. The exercise capacity is increased to almost 10 folds. ILD, which is my forte, and I have worked on this quite a bit. So what we have developed for our ILD patient is cryobiopsies. So if you identify what is the type of ILD, you can treat it better. So cryobiopsy is the new technique by which you can take a biopsy and make a proper diagnosis to give targeted therapy rather than a cocktail of steroids, immunosuppressants and antifibrotics. We are also running the first lung transplant clinic for patients with advanced ILDs and COPDs for transplant. For OSA, we have a type 1 level 1 lab for detecting OSA and the CPAP therapy for treating it. We have a state-of-art pleural services, especially thanks to the interventional radiology team that is there, in which we do guided intercostal tube drainages, CT guided biopsies, and we have also got thoracoscopy, by which we can actually see the pleura, take biopsies and give targeted therapy. So many times pleural effusions are being treated with anti-tubercular agents, but the diagnosis is still unclear, patient is not responding. At that point of time, a thoracoscopic guided biopsy would help in clinching the diagnosis and giving the proper treatment. And I'm also proud to tell you that the first lymphatic duct embolization was performed at RHL for chylothorax. So this is the first of its kind and it gives very good results. So even for very complex diseases, we have a solution. For COVID, our center fought at the forefront with comprehensive pulmonary care, and we also dealt with other complications, as Dr. Madhur told. We have been backed up by a very good intensive care team led by Dr. Narendra Rungta, Dr. Nitika and Dr. Sana. And during COVID, many of our patients off ventilator could get discharged and go home. So even for respiratory, so COVID now is probably has taken a back seat, but other respiratory infections such as swine flu, other viral pneumonias, bacterial pneumonias, we still deal with them, and we have the backup of ECMO, HFNC, BiPAP machines for the management. For the interventions, this is what charms most of the young pulmonologists. So we are currently we have rigid bronchoscope and we are doing debulking, stenting and balloon dilatation. So here in this picture, you can see a growth in the trachea. So this is, a short death sentence for the patient. So here we debulk the tumor and put in a Y stent. We have been the first center to start EBUS in the state of Rajasthan. So endobronchial ultrasound is a tool to detect, take samples from the mediastinal glands for easier diagnosis of tuberculosis, sarcoidosis and malignancy. Hemoptysis, we have running the bronchial artery embolization program, and we have performed the highest number in the state, which it has been done by our interventional radiology team led by Dr. Manish Rajput and Dr. Raghunath. I'm also proud to share that we have performed the first whole lung lavage in the state of Rajasthan for a patient of pulmonary alveolar proteinosis. Prior to this, we were actually referring the patients to PGI Chandigarh or AIMS. So we did this almost 2 years back now. We are also eagerly involved in research, and some of our publications have been published in very prestigious journals like Lancet, ERJ, and Journal of Allergy and Clinical Immunology. So I will just end with a quote from a very famous person. I can do things that you cannot, and you can do things that I cannot, but together we can do great things. Thank you. Thank you. And now we will break for coffee. Thank you.
Dr. Shyam S. Yadav. Dr. Pankaj Verma. Thank you very much. The next talk will be delivered by Dr. Ashish Malpani. The topic is ABC of spirometry. Dr. Ashish Malpani is working as a senior consultant pulmonologist at Asthma Bhavan since the last 13 years. He has special area of interest in non-invasive ventilation, sleep apnea, and interstitial lung disease. He has presented talks at various national conferences, and his papers have been published in many renowned journals. I now invite Dr. Ashish Malpani to stage, please.
Thank you, Dr. Anupriya. I think all of you charge up after the coffee break. So let's start the discussion about the spirometry. Various pulmonary function tests has been developed to diagnose the deranged respiratory system, and out of them, spirometry is the most common and the basic pulmonary function test. So what is spirometry? It is a physiological test that measures the maximum volume of air that an individual can inspire and expire with maximal efforts. It derived from the two words spiro and the meter. Spiro means to breathe and meter to measure. So actually it measures breath. Primary signal measured in the spirometry either volume or flow as a function of time, and it provides the objective tool to diagnostic information about deranged respiratory system, either obstructive or restrictive. And it also gives an idea about the early insight of pathophysiology of respiratory system by comparison of measured value with the normal predicted value of population of same age, sex, height, and gender. So procedure is the spirometry, and the instrument we using it is known as spirometer. Indication of spirometry. What are the situation in which cases you should do the spirometry? Objective evidence of obstructive versus restrictive disease, differentiation between asthma and COPD severity, to assess the progression of lung diseases, to monitor the effectiveness of therapy, to evaluate pre-operative patients. Spirometry is very important tool to measure the basic lung function before the cardiothoracic surgeries or predicting post-operative complications. Screen people at risk of pulmonary disease, like people or subjects involved in the dusty work, like in stone workers, in coal worker pneumoconiosis. Spirometry is very helpful screening the patients. Also, it gives for the fitness for the trekkers, hiker, mountaineers, and the marathon runners. So what are the contraindication? In which cases you should not do usually spirometry? Acute coronary syndrome in last 1 month, acute MI, recent eye, cardiac, thoracic, abdominal surgery in last 1 month, recent hemoptysis, pneumothorax and pulmonary thromboembolism, history of aneurysm, either cerebral, thoracic or abdominal, because there is a risk of rupture due to increased pressure. Late term of pregnancy, or patient develop vertigo, vomiting, or severe shortness of breath. In these cases, you should avoid the spirometry. So type of spirometer, basically there are two type of spirometer, volume dispensing and the flow sensing spirometer. Volume dispensing spirometer records the amount of air exhaled or inhaled within certain time. So primary signal is volume. And the second one, which is very commonly used nowadays everywhere, flow sensing spirometers, that measures how fast the air flow in out as a volume of air inhaled or exhaled increases. So primary signal is flow, which is indirectly calculated into the volume. So firstly, we will discuss about the some points, volume dispensing spirometers. As you see, there are many types of volume dispensing water seal, dry rolling seal, bellows spirometers. In these spirometer, water seal is the most common and gold standard. It measures the respiratory volumes when the displacement of bell occur, and this movement of bell is usually recorded on the rotating drum. As you see in this diagram, y-axis on the volume and the x-axis on the time. And the different respiratory values are generally manually calculated. But a disadvantage with the volume dispensing spirometer is that they are big, heavy, bigger in size, issue of infections, leak, and the values are generally manually calculated. So there is a chances of wrong interpretation. So now second type of spirometer is flow sensing spirometer, which we shall discuss only about the in presentation flow sensing spirometer. These are various type like pneumotachograph, hot wire, anemometer, rotating vanes, and now new introductions of ultrasonic flow sensor, which is based on the Doppler effect. Before proceeding into actual procedure of a spirometry, I will discuss some points about the lung volumes. So what are the different lung volumes? As you see in this graph, this is the tidal inspiration and the tidal expiration. We know that this is the 500 volume. If patient exhale normally or inhale, this volume is 500 ml. This is known as tidal volume. If patient inhale maximally after the tidal inspiration, this is known as inspiratory reserve volume, which is around the 3 liter. If after reaching the patient on the deep inspiration, if he exhale maximally, he can, then this is the deep expiration up to the maximally. So this is known as volume after patient reaching deep inspiration to deep expiration. Volume is known as vital capacity, which is very important in interpretation of the spirometry, which is around 5 liter. And volume remains after lung after the vital capacity is exhaled. It is known as residual volume, which is around the 1 liter. And total volume is remain after the normal tidal expiration. It is the functional residual capacity, which is around 2.5 liter. So mainly I would like to highlight the vital capacity, deep inspiration and afterwards deep expiration. So total volume is exhaled is the vital capacity. So now preparing the equipment, before starting the spirometry, we should confirm that our spirometry is of international norms. So what are the international norms for spirometer? The spirometer must be capable of continuous accumulating volume for at least 15 seconds, total volume at least 8 liter with flow 0 to 14 liter per second, and should have spirometer accuracy of at least plus minus 3% or plus minus 50 ml, whichever is greater. And resistance of circuit should be less than 1.5 centimeter of water liter per second. And it should be calibrated daily and cleaned properly before and after each procedure. So what are the activity and medication we should be checked? These should be avoided before the spirometry procedure. Activities like smoking with 1 hour, avoid meal within 2 hours, consuming intoxicants like alcohol within 8 hours, and vigorous exercise in 1 hour. Because smoking and the exercise can cause acute bronchospasm, so these affects the spirometry values. And medication which should be avoided: SABA short-acting beta 2 agonist 4 to 6 hours, short-acting muscarinic antagonist 12 hour, LABA for 24 hours, ultra-LABA, indectrol, vilantrol, odotetrol 36 hours, and LAMA, tiotropium, umeclidinium, acli, and glycopyrronium for 36 to 48 hours. These should be avoided before the spirometry within time limits. So before starting the actual procedure, operator or technician should wash her or his hand and use quality hand sanitizer. And technique and purpose of spirometry should be explained to the subject, and he should be made comfortable by making him understand that this is the non-invasive test. We have to measure just inhalatory and the exhalatory volume. We shouldn't not do any interventional procedure so that subject made comfortable. Brief history should be checked, indication, contraindication, and the medication. Measure exact age, height, weight, ethnic origin, and room temperature. And subject should be asked to empty his or her bladder before the procedure. So what are the importance of the height, age, and room temperature in the spirometry? We will discuss one by one. Measure height accurately. As you see in this picture, these are the two different patients of same age, same weight, and difference of height around 5 centimeter can lead to change in the predicted value about 300 ml. As you see, so we should measure the height accurately by using the stadiometer. It's the gold standard, or wall-mounted measuring tape, because any difference of 5 to 6 centimeter can lead to change in the predicted values. Second, measure age accurately. In this picture, if there is two patients of same height and age is difference, age of difference of 5 years can lead to change in the predicted values about 200, 300 ml. So age should be measured to the positive integers. Now third point is the measure room temperature accurately, because we are doing the spirometry at the ambient temperature and the pressure, and we have to measure the volume at the lungs, within lungs at the body temperature at 37 degrees centigrade. According to Charlie's law, if temperature is increases, volume is also increase. So if on the 21 degrees centigrade, if volume is 5 liter, then this same in 37 degrees centigrade, the volume will be 5.48 liter. So there we should keep an accurate thermometer in the room where we doing the spirometry. For this, the spirometry will automatically calculate the BTPS correction. What is BTPS correction is? It is correction is used to convert flow and volume measured and ambient condition, in which condition we are doing the spirometry, to the condition within the lung. So now preparing is continuous. So what is the ideal position to do the spirometry? Ideal position is sitting position, using a chair with arms and without wheel, and standing position can be used in the children, pregnant, or very obese person. And subject should be asked to lose his clothing, tie, or vest belt. Loose fitting denture should be removed. If denture is tight fitting or well fitted, can be left in place. Nostril occlusion by nose clip or manually occlusion is now optional. Practical demonstration is utmost importance to the subject, is very important. We should demonstrate all the procedure we are doing in the spirometry. So now comes to the actual procedure of a spirometry. There are two methods of doing this for doing spirometry: open circuit method and the closed circuit method. We will discuss firstly open circuit method. What is open circuit method? Firstly, breathe in until the lungs are full. Lungs are full means we have to inhale, a subject have to inhale up to deep inspiration, and hold the breath and seal the lip tightly around the clean mouthpiece, and then blast the air out as forcibly, as fast as possible. There should be lots of encouragement, and then continuous blowing until the lungs feels empty, and again breath in until the lungs are full. So first phase of inspiration is nice deep inhalation up to maximum inspiration. Take a nice deep breath in. Subject should be asked to fill your chest as much air you can. Second, blast. After seal his lips around the mouthpiece, subject should be asked to blow as fast as he can. Blast maximum. Third, continue to remove as much air as possible, blow for as long as he can blow. And at this point, technician should motivate the subject to doing the continuous speaking the some encouraging words like karte raho, very good, bahut badhiya, so that we can get the good spirometric values. Last process, ultimately after, take a deep inspiration. So this is the complete process of doing spirometry. Nice deep inhalation, blast, and then blow, and fourth and last, take deep inspiration. So after the doing FVC maneuver, different values we receive. What are the different values? FVC, force vital capacity, the total volume of air that can be forcibly exhaled in one breath after the deep inspiration. FEV1, fraction of vital capacity expired during the first second of forced expiration. FEV1 upon FVC ratio, fraction of air exhaled in first second relative to total volume exhaled. FEF 25 to 75, rate of flow of exhaled air mid of force vital capacity maneuver. And FET, force expiratory time, which is the total duration of deep exhalation maneuver. So how many blow are recommended in particular one session of spirometry? A maximum of 8 blow. How many? Maximum of 8 blow. Out of 8 blow, we have to get at least 3 acceptable maneuver. What are the acceptable maneuver? We will discuss later. And we should give subject to at least 30 seconds between the two maneuver so that he can recover from the last maneuver. So what we will receive after the spirometry? 2 types of graph. What are the 2 types of graphs? First one is flow volume graph, and second is volume time. In flow volume time, flow on the y-axis and the volume on the x-axis. In volume time, volume on the y-axis and time on the x-axis. So as you see in this graph, the flow volume curve, this is the steep rise, almost parallel to the y-axis, and there is a good peak. And then continuous and smooth descent of descendary limb and making acute angle with the x-axis. And then the complete inhalation to make the complete loop. So above the graph this is the expiration, and below the graph this is the inhalation. So we start spirometry procedure when patient inhale to deep inspiration. We start the procedure here, patient exhaling to the residual volume. So because volume remains after the lung, after the force vital capacity is exhaled, it is residual volume. And after then repeat deep inhalation again to the total lung capacity. So this is the flow volume curve. And now look towards the volume time curve. As you see in this graph, there is a reaching a plateau. Plateau, what is mean of plateau? Straight line. There is a change in volume of less than 25 ml. As you see in this graph, there is a almost straight line. So this is a plateau. Plateau should be there, and adequate test we require of minimum of 3 acceptable FVC maneuver. So when we set this maneuver, we should have to conclude end of force expiration criteria. The volume time curve show plateau for 1 second, or subject has tried to exhale greater than 3 seconds in children and greater than 6 seconds in adult greater than 10 years of age, or patient has achieved FET, force expiratory time, for greater than 15 seconds, or subject cannot continue further exhalation and develop syncope, dizziness, chest pain, bronchospasm, or breathless. In these cases, we should conclude the spirometry. In spirometry, two criteria are very important: acceptability criteria and the reproducibility criteria. What are the acceptable criteria? Without effort should be without a poor effort, without agitation, without coughing during the first second, without early termination, and FET more than 6 seconds. As we see in this graph, their poor efforts leads to the low FEV1 reading and there is no peak. Hesitant start before the starting any procedure also leads to low FEV1 reading. Cough in the first second, very important. Cough in first second is unacceptable criteria. We should do repeat the spirometry if subject develop cough in first second of expiration. Early termination, sometimes subject completely, suddenly cessation of airflow occur due to glottis closure. This also leads to falsely low FVC. These are the different flow volume curve pattern in obstructive and the restrictive disease. As you see in obstruction, there is a no peak and the descending limb of the curve is scooped out and very much concave. And very severe obstructive disorder, concavity become more prominent and this lead to a specific pattern, rat tail or dog tail appearance. Second important point, repeatability or reproducibility criteria. If we get 3 acceptable FVC maneuver, then we should check for the repeatable criteria, that this is the confirmation that patient has exhaled maximal of his effort. So FVC repeatability or repeatability criteria, FEV1 or FVC should be less than 150 ml. So now we proceed into the interpretation of the spirometry. Firstly, we go for the FEV1 upon FVC ratio. If it is more than 70%, then we go for looking for the FVC. If FVC is normal, then it is the normal spirometry. And then if FVC is reduced less than 80%, then it is the restriction. If FEV1 or FVC ratio is less than 70%, then one point is sure there is some component of obstruction. Then we differentiate between bronchial asthma and COPD by providing the bronchodilator response. These are the severity of obstruction and restriction. Obstruction on the basis of FEV1 and severity on the restriction. So take home messages. Spirometry is an effort dependent procedure, so technician should motivate subjects to give his or her best result. And before interpreting any spirometry, we should check the acceptability and repeatability criteria. If we don't get the acceptable repeatable criteria, then we should go for the interpretation and we should repeat the procedure. Spirometry not a sole criteria for diagnosing lung disease. It gives you idea about the abnormality. So disease should be confirmed by far advanced tests like clinical, radiological or advanced tests. I would like to end my presentation with a beautiful quote of Winston Churchill. Success is walking from failure to failure with no loss of enthusiasm. This is perfectly fits into the spirometry as well. If we don't get the good acceptable and repeatable criteria, we don't lose hope. We should repeat the procedure with same enthusiasm. Thank you. Yeah, pregnancy spirometry can be done in early cases of pregnancy in first trimester, but late pregnancy is absolute contraindication. Mention.
Thank you, Dr. Ashish. Any other questions? I think we can take after other lectures because we are off the limits now. I think the most important take-home message is to please do spirometry. Every patient who is coming with breathing difficulty. That is very, very important. And second most important, to teach your technician to demonstrate very well to the patient how to do it. If demonstration is poor, most of the patient who comes to us don't understand it. That's why it's very, very essential
to demonstrate them how to do it, and as I said, do it very well, try to demonstrate so that they can replicate what you are doing. Thank you.
Thank you very much, sir. A gentle reminder that the event will be followed by a very delicious dinner by a very famous chef at Hotel Lalit from 7:30 p.m. onwards. The next talk will be delivered by Dr. Nishtha. She'll be talking about how to manage asthma. Dr. Nishtha is the Executive Director and Senior Chest Consultant at Asthma Bhavan, Jaipur. She has special interest in treating asthma and allergy. She has presented various research papers in national and international conferences. She has specialized in various procedures and has pioneered IBUS in Rajasthan. She has been awarded Dr. S.K. Sarkar Best Research Paper Award in 2019 and the Indian Chest Society Best Lung Indian Publication on IBUS at NAPCON at Kochi, November 2019. I now invite Dr. Nishtha to the stage, please.
It's not visible. Okay, thank you so much for the lovely words, Dr. Anupriya. My difficulty here is to how to substantiate those words in my talk. So I will be talking about the management of asthma today. First of all, I would like to ask you all, what is the most common patients you see in the chest OPD? How many of you say TB? Please raise your hands. And COPD? How many of you say COPD? And how many of you say asthma? Well, friends, earlier it was all a speculation. We were depending on the international data for answers. But now the answers are with us with the Indian data because we conducted a study, SOAT study, and it was found out that asthma is the most common disease that is coming up in the chest OPDs. And another question, what are the best and worst seasons for asthmatic patients? So it has been seen that summer, the May month is the best, while autumn, that is November, is the worst season. Coming to the management part, what do you think is the percentage of patients who take appropriate asthma treatment? 75%, 50%, 25%, 10%? And friends, yes, the answer will shock you all. Because it is only 6 to 11% of the patients who are taking appropriate treatment. And why is that so? What are the rest of the population taking? They are taking other medicines like oral medications like tablet Asthalin, salbutamol. We all know that salbutamol is associated with side effects like tremors, palpitations. Montelukast has been known to cause cognitive impairment and so many other problems. So it is very important that we give the appropriate treatment to these patients. But how is it possible that in such a busy OPD, we give appropriate asthma therapy to the patients? My task today is to make that possible. So Gina has helped us. I know that you know Gina, but I want you to apply that Gina in your busy OPD. So only 4 questions and the 4 symptoms. That is all about asthma. I want you all to, whenever you go out of this hall, you should remember these 4 questions and 4 symptoms. The first is day symptoms. Second, nighttime awakening. Nighttime awakening because of those day symptoms. Then activity limitation because of those 4 symptoms. And reliever medicines in order to curb those 4 symptoms. And what are the 4 symptoms? W, C, C, B. W for wheezing, B for breathlessness, C for cough, and C for chest tightness. So if you ask the patients only these 4 questions, then you will be able to give them appropriate asthma treatment. This is the stepwise management that you all know, and it is published in the GINA guidelines. So to simplify it, the step 3, 4, 5, I have written LMH. L stands for low dose maintenance ICS formoterol. So in all step 3, 4, 5, maintenance ICS formoterol is the same. The only difference between the 3 steps is In step 3, it is low dose. In step 4, it is medium dose. And in the step 5, it is high dose. And step 1 and 2 have got low dose ICS formoterol as SOS therapy. So my talk is about 3 things today: how to initiate asthma therapy in a new patient, how to continue treatment, follow-up of those patients, and third is the asthma action plan. So how to initiate therapy in a new patient? So the new patient, when you are initiating the therapy, out of the 4 questions, you need to answer only two of them. First is, if the patient is having daytime symptoms of greater than equal to 2 per month to less than 3 per week, then you have to start with low dose ICS plus formoterol SOS combination. And this is the patient is falling in the GINA step 1 and 2. Now, another patient comes with daytime symptoms most of the days. And if the nighttime awakening is present for greater than equal to 1 per week, then it is GINA step 3. Remember that either of these 2 symptoms should be present. And then you have to advise for low dose ICS plus formoterol daily. Now coming to the step 4, we want both these symptoms now in the patient. 1, daily daytime symptoms, and 2nd, nighttime awakening for greater than once per week. If both the criteria are fulfilled, then we are going to advise the patient medium dose ICS plus formoterol. So remember, what is low dose, what is medium dose, what is high dose? This is a chart that you have to remember, but I will make the task easier for you so that you can remember it. Just remember the medium column. That is, medium budesonide is 400 to 800. Medium fluticasone propionate is 250 to 500. Anything lower than this is low dose. Anything higher than this is high dose. Let's take an example. This is a patient Mohan, who's 30-year-old, and he was a known asthmatic in childhood. But when he became 13 years, his asthma got cured. But now, from last 2 months, he is complaining of cough and breathlessness while walking and climbing stairs. He has chest tightness on most of the days with no nighttime awakening. His PFT is showing bronchodilator reversibility. So, we diagnose him with asthma with greater than 200 ml and greater than 12%. So, how to initiate treatment in this patient? Looking at those 4 questions. So, the 4 questions. Now, as you can see that the patient has no nighttime awakening. Here, no nighttime awakening, and the daytime symptoms are present for most of the days. Chest tightness is present on most of the days, that is greater than 4 per week, and either of 2 are present, then it is step 3. If both of these 2 are present, it is step 4. So, one of them is present, so the patient is falling in the step 3 category. So, this is the prescription you have to give to this patient. You have to start him on the maintenance formoterol budesonide combination and give him a formoterol budesonide reliever therapy. So in the GINA guidelines, earlier it was salbutamol that was used as SOS therapy reliever, but now it has been replaced by formoterol ICS combination. This is a very remarkable change that has been done in the GINA. And apart from the treatment, you also need to ensure that the patient is not coming in contact with these triggers. So otherwise, you will have to keep on increasing your dose. So triggers can be allergic, non-allergic. So after 1 week, furious Mohan came back. So he said, "Ma'am, चींटी को मारने के लिए हथौड़ा you gave me steroids for only treating my occasional cough, and steroids are the most harmful medicine." I asked him, "Who told you?" So he told me, Dr. G told me. I thought it is Dr. Gopal. And I said, "Is it Dr. Gopal?" No, Dr. Google. Oh, this Google is like, people are becoming so intelligent. So, but we need to clarify their doubts as well. So I asked him, "What is the name of your disease?" The patient said, "It is cold cough." "No, it is asthma." The patient said, "I don't understand asthma. You tell me a Hindi name." So I asked him, "Okay, your name is Mohan. What is your English or Bengali name of Mohan?" So he said, "No, name remains same in all languages." So I said, "Disease name also remains same in all languages." So patient said, what is your evidence? So this was the study that we did that included and recruited 547 asthmatic patients. And it was found out that only 23% of them knew their disease as asthma. Others knew by various names like SARS, cough, dama. So you have to motivate the patients to speak asthma to defeat asthma. So patient again came to his question, but you did not answer my question, doctor, that why did you give me steroids in the mildest disease? So I showed him these two pictures. So one is the normal person and second is the asymptomatic asthmatic person. And I tried to explain him about the inflammatory cells. Look at the remarkable number of increase in the inflammatory cells. And looking at these pictures, he was rest assured that, okay, yes, the treatment that was given to me was correct. After some time, Mohan brought his mother to me. She was a 52-year-old lady. She was already taking formoterol budesonide 400 md at 2 puffs twice a day for last 6 months. So last month, almost daily her sleep was interrupted due to bad cough. Cough restricted her to go to farm 3 days back. Coughs a lot during daytime kitchen work. Applying our 4 questions. Now we are doing the continuation of the treatment. The first part was how to initiate asthma treatment. Now how to continue the treatment. So we need to figure out whether the asthma is controlled or not. So looking at these 3 things, one is none. If all these 4 questions, the answer is no, that means the patient is controlled and you need to reduce the dose. And if any 1 or 2 is correct, yes, then the patient is partly controlled and you need to continue the dose. And now if many 3 or 4 are yes, the answer is yes, then you have to review and optimize the treatment. So this patient was having yes answer in 3 parts. One is daytime symptoms greater than twice per week, nighttime waking, and any activity limitation. So this is a very important thing that we need to remember because asthma has got so many factors involved in this. So during the OPD, we need to ask all these factors whether these are not treated or not. So to make it easier to remember, we have built this new mnemonic. This is TAT-TOS. So this mnemonic covers everything. Check for the technique of the inhaler. A for adherence. 3, diagnose whether any comorbidity is present or not. Then triggers are present or not. Any other triggers. Then optimize the treatment and the spirometry if FEV1 is less than 50% or not. So with TAT-TOS, modified treatment, her asthma got controlled in 1 month time and Mohan got satisfied. So looking again at the GINA guideline stepwise therapy. If you look at the mother, then she was already taking the medium dose maintenance ICS formoterol. She was taking 400 md at 2 puffs twice a day. So, and we also saw that she was coming in the many group, none, any, many. So she was falling in the many group, she was uncontrolled and we need to review and optimize. So when she was falling in the medium step 4, then we needed to bring her to the step 3. So we jumped up her treatment and added few of these other agents. Now the last portion of my talk is the asthma action plan. So this is a written document that you can give to the patients so that they keep their asthma symptoms under control and they have a good control of their own disease. So it is divided into 3 zones. One is green zone, yellow zone, red zone. Green zone is a good zone. Maximum all patients you should try that they should remain in the green zone. When the patient does not have any asthma symptoms, he has normal activity, sleep, no symptoms, then in such kind of patients, we ask them to continue their treatment. And if the patient starts having any of these signs, then the patient has come in yellow zones. What are the signs and symptoms? The patient is having asthma symptoms, nighttime waking greater than 2 per month, or the patient is having activity limitation, or the patient is having reliever use of greater than 2 per week, or PEFR is 50 to 79% of best. Then you have to start the reliever medicine, and that is to be given every 4 to 6 hourly. And if it is still not better after 24 to 48 hours, then the patient is asked to call their doctor. Now, if the patient's symptoms, that was the yellow zone. Now we come to the red zone. Red zone is the danger zone. The patient's asthma symptoms are very severe and they are not responding to the yellow zone treatment. The patient is having uncontrollable cough. The PEFR is less than 50%, then increase reliever, and if not better in 30 minutes, then call the doctor. So my take-home message is only 10% of patients take proper treatment. 4 aspects, 4 questions. They can help you save in any day, and you can treat your asthma patients accurately and correctly. ICS LABA is both reliever controller. Use slogan like speak asthma to defeat asthma. Use TAT TOS review. Thank you.
Excellent lecture, Nisha. Very nicely presented the way to treat asthma in a very especially case formation way. Any questions from the audience?
When to stop treatment of patient? When can we ask him you can stop treatment after 3 months?
Generally, this is a very good question, and this is a very common question also that patients ask to the doctors. But asthma treatments are generally not to be stopped. We should the treatment that is to be given to the patients is the ICS, low dose ICS formoterol combination inhaler to be kept with him as SOS, reliever therapy. That is the lowest we can give to the patient. So it is always to be kept with the patient.
नॉर्मली जब भी पेशेंट ओपीडी में आते हैं हमेशा पूछते हैं डॉक्टर साहब पंप की आदत लग जाएगी, तो उन्हें आप रिप्लाई किए कुछ आदत अच्छी होती है. इट्स अ गुड हैबिट टू यूज स्टेरॉइड पंप टू अवॉइड रिकरेंट इवेंट्स एंड स्पेशली सीवियर अस्थमा.
एंड आदत होती है कॉफ़ी की, आदत होती है चाय की. ये आदत तो अच्छी है अपनी सेहत के लिए.
Similarly, one more thing you should do in the OPD, whenever you advise MDIs or pump, please demonstrate them. Most people don't know how to use them. So the first key was to demonstrate the technique. If people they don't know, most of the people, if you see 2 or 3 patients, you will laugh on every patient how they are taking the inhalers. I think Dr. Vinder Singh will demonstrate much further. But please try to just call them again with pump and explain them how to take it.
And sometimes the patients take the capsules as an oral capsule rather than putting it in the inhaler. So it is very important to tell them that it is not to be taken orally with the water or milk. It is to be put in the rotahaler and then any DPI.
So thank you, Dr. Nisha. Yeah.
I think same question, sometimes what happens, patient goes symptomatically 15 days, 20 days, then he or she feels I'm now better, why should I continue my medicine? That's why I want to know when you can ask patient, you can decrease your dose,
It is 3 months is the time that is taken as the duration. You need to ask the patient that before stopping the treatment, you need to take the treatment for at least 3 months. Then come back to the doctor. Ask him or her what is to be done. And we don't stop the treatment immediately. It is to be done in a stepwise order, like the GINA guidelines. From step 4, we go to step 3, then we go to 2, then 1. 1 and 2 also say that it is to be taken as SOS therapy. You need to keep that inhaler with you as a reliever. Oral fungal infections are very common, so it is important that after taking inhaler, nebulizer, any form of inhaler, then you need to take proper oral kulla or gargles that are to be done. Otherwise, after some time, your patient will come to you with hoarseness of voice, fungal infections in the mouth, and they will say that our taste has changed. So these are very small, minute things that you can educate your patients, and they will be really grateful to you.
To high
high dose therapy?
Like told you in the lecture also, that is a very important question and nice question, because that was the question that was coming in our mind also. So TAT-TOS, if you are completely sure that you have rectified all those TAT-TOS things, trigger factors are completely rectified and all those adherence is checked, whether the technique is also corrected, most of the times any of these 6 criterias, if you fulfill them completely, then the patient gets controlled with the high dose. It is seldom required that you need to give him higher than the higher dose in asthma. But still, if you are thinking that the patient is falling in the category, then there are basically 2 category of the things that are available. One is the biologics and second is the thermoplasty, that Dr. Shitu has also said that we have introduced thermoplasty. That is the first time in Rajasthan. It is the center where thermoplasty is being done. And other are the biologics. Biologics studies are still going on. Omalizumab, benralizumab, they are available. And their response is being judged, and it is under observation, and probably good results will come out of it.
तो ट्रिगर्स के लिए कई पेशेंट पूछते हैं कि भाई किस चीज़ से होता है ऐसी कोई जांच, जैसे मोस्टली तो ट्रिगर्स ये होते हैं कॉमनली तो डस्ट एंड एनी स्पेसिफिक.
So triggers के लिए there are 2 things. One is the clinical history. Ask the patient, you only tell me what are the clinical, when do you think that your asthma increases? What all things did you come in contact with? He can also make a table at their home daily, what all triggers they were coming in contact with, any food articles they were having, ingesting every day, and whether they were increasing their asthma symptoms or not. One thing. Second point is the test that are to be done. One is the allergy test. So allergy test is done by 2 methods. One is the SPT that we do, that is the skin prick test, and second is the immunocaphadia test that we do, that is done by blood samples. So they mainly measure the IgE levels of the blood to specific allergens. So both of these tests can be done, but the gold standard is the SPT, skin prick testing. That is the gold standard. So I advise you that you also advise your patients to get the allergy test, SPT, skin prick test done for themselves.
So for that we have to send the patient at like that center.
Yes, we are doing it here also. We are doing at Asthma Bhavan. So I think maximum number of allergy tests we have done at Asthma Bhavan till now. So you can send it anywhere.
Is there
That's
any
your
role
choice.
of Montelukast levocetirizine with ICS and this?
That comes in the last step, yes. Montelukast has been known. In fact, if you read GINA guidelines, so many times it has been mentioned, 4 or 5 times. That is the minimum amount I'm telling you. But it has been mentioned that it is associated with cognitive impairment. In fact, depression, suicidal tendencies that have been associated with this. So it is better if you start with this only. Basically, Montelukast cetirizine combination is given for the allergic rhinitis that is associated with the asthma patients. Then we have to give.
There is no role in bronchial asthma.
Bronchial asthma, the rule is on the step 4 or 5 later on.
And for how long we can prescribe that Montelukast?
Montelukast levocetirizine is generally prescribed for 6 to, that is depends on the patient's symptoms, but 6 to 8 months you can prescribe it.
Thank you.
Thank you, Dr. Mishra. We can conclude the session now.
Thank you, Dr. Nishtha. That was a very informative talk. The next talk on how to manage COPD will be delivered by Dr. Virendra Singh sir. Dr. Virendra Singh sir is the president of Mahavir Jaipuria Rajasthan Hospital. He is a leading asthma specialist of our country and is considered as a pioneer in the field of respiratory medicine, in which he has worked since last 40 years. For his enormous contributions, sir has been awarded Dr. B.C. Roy Award, which is the highest medical award in the country. Before starting Rajasthan Hospital, sir retired as superintendent of SMS Medical College, Jaipur, which was also his alma mater. He also serves as the director of Asthma Bhavan, Jaipur. I now invite sir to the stage, please.
Ladies and gentlemen, at the outset, I am thankful to you all. We started this hospital almost 2.5 years back. It coincided with onset of COVID. I and my close friend Dr. Shyam Sundar Agarwal. And now since their COVID is receding, we thought that we should have a physical meeting. The basic aim of this conference is to enhance the practice, to enhance the ethical and accurate practice with a sort of precision medicine. Friends, actually Dr. Nishtha taught me that among COPD and asthma is having higher prevalence, that's why I'll speak first. I said, okay, you speak first. So, how to manage COPD? I'll discuss, and I'll take two parts. One is the magnitude of the problem of COPD, and other is the how to reduce morbidity and mortality. Which disease causes maximum death in India? Any guess? Just shout yourself. Which disease causes maximum death? Coronary artery disease. Myocardial infarction and coronary artery disease kills maximum Indians. And which is second one? Second one is, I'll tell you, I start from the global perspective. In 1990, COPD was fourth killer globally, but in 2010, it became third. And in India, it is 2017 publication. We were also part of that publication in Lancet, where the global burden of disease data showed that COPD kills is at second place. It is the second biggest killer in India. And what about Rajasthan? And if you see the prevalence, then prevalence of COPD globally is almost equal to the population, that is 16-17%. But as far as death is concerned, it kills 30% in India. That does mean global average, it kills double of the persons suffering from COPD in India. And what about in Rajasthan? In Rajasthan, it is the top killer. It is top killer, even pushing ISD at the second place. You will see that per lakh of the population, 111 dies due to COPD, while 95 dies because of coronary artery disease. So, summarizing it, globally it is at the third rank, nationally it is at second rank, and at Rajasthan level it is the top killer. So, it is important to learn about this for every doctor sitting here. Now I discuss a patient, Ramesh Mukherjee. He is 54 year age, 30 pack years of smoking history, cough, sputum, wheeze and breathlessness. What is your clinical impression? If we come across various prescriptions from hundreds of the person, then these are usual diagnoses we come across. Almost 8 of you. Have you seen? Do you agree with me? Anybody not agreeing with any diagnosis? Probably you have also witnessed these diagnoses on prescriptions in cross references. Okay? But I usually use only these two diagnoses, asthma and COPD, because all other are
not precised and though not acceptable medically. So, cough in COPD, if we talk, cough may be productive, even unproductive, or it may be associated with wheeze. So that gets confused. Sputum on and off. It is not necessary that continuous 3 months for 2 consecutive years, that is the definition of chronic bronchitis. Breathlessness, it is persistent, progressive, and exercise induced. That is very consistent feature. And risk factor, there should be either smoke or there should be dust. Now, how to confirm the diagnosis? Can anybody shout in response? How to confirm diagnosis of COPD? One tool which Dr. Ashish Malpani very vividly discussed is spirometry. And probably among even our chest physicians group, when we asked, usually people get ECG more frequently than spirometry. Rather, it should be paradoxical, because COPD patient and couple of asthma and COPD are constituting almost 50% of chest OPD. There should be equal proportion of spirometry as well. Spirometry is ECG of lungs. So you can see in Ramesh, we got chest X-ray, hyperinflation, sputum. In our country, every COPD patient's workup should involve sputum examination. That is Indian guidelines. I was also part of that. And because of high prevalence of TB. Then spirometry pre and post showed 63%. Less than 70% is obstruction. So it is less than 63%, it is airway obstruction. Now airway obstruction is due to asthma or COPD, because there was 12% increase and more than 200 ml, then it is asthma. If either is less than this limit, 200 ml absolute and this, then we will say it is COPD. So our patient is COPD. And in the similar manner, I also discussed, as Dr. Nishta discussed, then ultimately he agreed to speak COPD. But he said, कि साहब COPD top killer तो है, but इसको कैसे याद कैसे करें? I said, where you consulted me? He said, in OPD, sir. Just put C. What is now? COPD. Yeah, so simple. Because SARS was the most common terminology, but accuracy was only 39%. Positive predictive value. It was only 39%. So SARS is very commonly used, but its predictability, accuracy is only 39%. When a patient used term COPD, the positive predictive value means accuracy was 100%. So we should teach our patient, speak COPD, defeat COPD. Ramesh has 32% and it is 35%. Now, if we see the 4 grades of gold, then you can see it was 32%, 35% post-bronchodilator, meaning by he is having severe COPD. Severe COPD. What is aim of treatment? Aim of treatment are 2. 1, reduce agony of dyspnea or the symptoms, and 2, the risk of exacerbation should be reduced. Risk of exacerbation is equivalent to risk of death. Why? Here is a beautiful comparison of 2 big diseases. One is cancer and other is COPD. You can see cancer patient goes slowly down to die almost in a year. But in COPD, if he has 3 episodes of exacerbation, if this is the hypothetical line of incompatibility with life, when body function gets reduced to this level, every exacerbation is very near to this line. So any exacerbation of COPD patient can kill him. And probably that is the reason why so many people are dying in our nation. Now, we can, Gold has given very beautiful chart, rather 4 categories we can adopt in our practice. We can adopt our in practice, and that can rationalize therapy, and that can improve our prescription. What are they? One is COPD exacerbation. 3 types. One is mild, when patient says, हाँ साहब मैंने कुछ लिया था bronchodilator and I got cured. Second, moderate, controlled with a course of antibiotics and oral steroid, that is moderate. And third, when patient is admitted and he is given injectable things. So moderate type of COPD exacerbation is one thing, and other is agony, that is the dyspnea. So friends, just memorize 2 questions. One, magnitude of dyspnea. 2, risk of exacerbation. So I in my practice ask, do you walk slow? आप अपनी उम्र के लोगों के साथ बराबर चल पाते हो? One question. Second is, पिछले साल में कितने आपको अटैक्स हुए COPD के, जिसके लिए आपको एंटीबायोटिक या एक्स्ट्रा स्टेरॉइड लेना पड़ा? These 2 questions if you memorize and get into practice of asking from your patient, probably you can use ABCD, where A is when these are 2 scales. This one is dyspnea. Modified MRC grade of dyspnea, if it is less than 2, then it is A and C. If it is more than 1, means 2 or more, it is B or D. So this question will differentiate. If this question is yes, then it will go into B and D. If this question is no, then it will be A and C. Similarly, if you have exacerbation 2 or less, it is A and B. If it is more than 2, it is C and D. But if exacerbation of magnitude of admission into hospital, then it will go into upper level. AE last year. Here you can see that he had 3 episodes, but he was able to walk with his colleagues of same age. So it is no. So no means he is in this group, and 3 means he is in C category. What medicine should be given in A, B, C, D? Any idea? What medicine should be given in A, where patient is having? Patient, you can see less symptoms and low risk, A. Less symptoms and high risk is C. More symptom and less risk is B. And more symptom and high risk is D. So you can see as needed therapy of a bronchodilator is sufficient in A category. In B category, 1 or 2 dual bronchodilator is good enough. In C category, 1 or 2 dual, but if exacerbation are high, then we should add what? What? ICS, inhaled corticosteroid should be added, and in D, triple therapy or roflumilast, if there, that can be used. But there is a rider. There are alternative if patient is not improving, we can use them. ICS. In category D, we can use these alternative. Now the biggest question is, should we use ICS in any patient who is having frequent exacerbation? Yes or no? We should not. We should, those patients who are having history of hospitalized exacerbation, yes, that is indication. Those patients who are having more than 2 moderate exacerbation, and those patients who are having eosinophil count more than 300, then yes, that is the group that is strongly supported by use of ICS in COPD. But if these are 2 moderate exacerbation, eosinophil between 100 to 300, we should be cautious. But these are no for ICS, meaning by if eosinophil are less than 100, please don't use. If patient is having history of TB in past, we should not use this thing. And repeated pneumonia if patient is having, then we should not use. Rather, we should remember this no category. Okay, so yes, 1 minute I am having. Okay, then the patient was a smoker. He said, "Sahab, ab mere ko theek kar do." So I said, "Your lungs are burnt." कितने जल गए थे? 35 थे ना? I usually use spirometry in that. I said your 65% lungs are burnt. अब यहाँ पर आग लग जाए, ये चिलम भी पीते थे ना, तो आग लग जाए तो आग पहले बुझाओगे या टांका पहले लगाओगे? जवाब क्या आएगा? आग बुझाएंगे। तो आग बुझाओ, 100% आग बुझाओ। आप he got convinced and he stopped smoking. So friend, last 2 slides. Avoid road pollution, prevention of exacerbation by using influenza and pneumococcal vaccine, and rehabilitation. And in the last, COPD is the top killer. We should design our own methodology how to prevent it. Use spirometry in diagnosis of COPD. Will you use? Those who will use COPD in spirometry in COPD, raise your hands. अरे किसी ने हाथ नहीं खड़ा किया? ठीक है. One question to assess symptomatic status and one question to assess exacerbation. ABCD should be used in treatment of COPD and smoking cessation, vaccination and rehabilitation. Thank you very much.
Question from the audience. Excellent lecture. My take home message is this: we usually miss to ask the second question. कि पिछले 1 साल में आप कितनी बार आपने एक्स्ट्रा दवाई ली या कितनी बार आप एडमिट हुए? So that should be taken into account before deciding your medicine. That's a very important take home message that you should take. And another question, anybody want to ask?
Okay. Thank you very much.
Thank you very much. Thank you, sir. Thank you so much.
Thank you very much, sir. The next talk will be delivered by Dr. Sana. The topic is nuts and bolts of BiPAP CPAP therapy. Dr. Sana is a young and enthusiastic critical care consultant at Rajasthan Hospital, Jaipur. She is an anesthetist and her areas of interest include pulmonary critical care and ECMO. She has been pivotal in her work in taking care of COVID-19 patients on ventilator, and her zeal and enthusiasm are unparalleled. I now invite Dr. Sana to the stage.
I would request everyone to please stay for the while for the last lecture of the evening, because it's a very important topic. In the COVID times also, the use of pipette was very much needed by everyone. So please sit for a while to listen to some important topic of pipette by Dr. Sanam. Thank you.
And friends, one announcement I forgot, that tomorrow there will be wonderful lectures and sessions, especially tips in rehabilitation. Rehabilitation is very important thing in respiratory care, and there will be very attractive lectures. So don't forget to be here tomorrow. And tonight we are having very delicious dinner. So stay here, and there will be 4 stations. Now, Dr. Shitu will tell you. So please stay here.
Just a small announcement. We have the first of its kind 5 stations. That is a small booklet. I will be describing all of that in a short way. Just stay with us for BiPAP, and then we will split into stations. Thank you. Over to Sana.
Thank you, Dr. Anupriya. Hello. Good evening, everyone. My topic is non-invasive ventilation in acute care settings, that is in ICU, and in chronic care settings, that is at home. What is non-invasive ventilation? It refers to the delivery of positive pressure ventilation through non-invasive surfaces like face masks, nasal plugs, rather than an invasive interfaces. In acute care settings, the benefits of non-invasive ventilation in acute care settings: it reduces the need for endotracheal intubation, reduces incidence of ventilator-associated pneumonia, shortens the stay in the intensive care unit, shortens hospital stay, reduces mortality, preserve physiological airway defenses, improve patient comfort, reduces need for sedation. And in chronic care settings, it alleviates symptoms of chronic hypoventilation, improves duration and quality of sleep, improves functional capacity, and prolongs survival. And next is, what is the mechanism by which NIV helps in improves gas exchange? It gives positive pressure, inspiratory and expiratory, during inspiration and during expiration. Inspiratory positive pressure unloads respiratory muscles and decreases the work of breathing. Positive and expiratory pressures causes increases in FRC by recruitment of lung units, which causes improvement in compliance and improves oxygenation. Positive and expiratory pressures, like in cardiogenic pulmonary edema, it decreases preload and decreases afterload and improves cardiac output. PEEP in COPD patients offsets auto PEEP, unload the respiratory muscles, and it decreases the work of breathing. Indications for NIV, it is a long list, but I have divided it into 2, in acute care settings and in chronic care settings. In acute care settings, 4 important indications are: first is acute exacerbation of COPD, acute cardiogenic pulmonary edema, in immunocompromised patient with hypoxemic respiratory failure, and in 4th is facilitation of weaning in patient with COPD. These 4 indications have strong evidence, and these patients are more likely to get benefit from NIV. Other indications in acute care settings include asthma, community-acquired pneumonia in patients with COPD, do not intubate patients, hypoxemic respiratory failure, post-operative respiratory failure. These have intermediate evidence for use of NIV.
Next is ARDS with single organ involvement, community-acquired pneumonia in non-COPD patient, cystic fibrosis patient, facilitation of weaning and or extubation failure in non-COPD patients, trauma, and upper airway obstruction. These later indications have weaker evidence, and these patients are less likely to get benefit from NIV. In chronic care settings, the indications are central sleep apnea, obesity hypoventilation syndrome, OSA, OSA with combined COPD and CHF, chronic stable COPD, and multiple restrictive diseases, including neuromuscular diseases, slowly progressive neuromuscular diseases like multiple sclerosis, muscular dystrophy, amyotrophic lateral sclerosis, post-polio syndrome, stable spinal cord injuries. But two diseases, neuromuscular diseases, like in myasthenia and GBS, it is not recommended because these are very rapidly progressive neuromuscular diseases. Next is indications. We have learned symptoms and selection criteria for in acute care settings. In the symptoms which we should use NIV in these are moderate to severe dyspnea, respiratory rate more than 24 beats per minute, use of accessory muscles, and paradoxical breathing. The physiological criteria include PaCO2 more than 45 and pH less than 7.35 or PF less than 200. Important is what are the exclusion criteria? What are the patient we should not use NIV? So first is respiratory arrest or near arrest patient, or the patient who need immediate intubation. Hemodynamic instability, inability to protect their airway because of impaired cough or swallowing, excessive secretions, agitated and confused patient, patients with facial deformities or condition that prevent mask from fitting, uncooperative, unmotivated patients, patients with brain injury with unstable respiratory drive. This table includes the symptoms and physiological criteria in chronic care settings. So in the patients with restrictive thoracic disorders and neuromuscular diseases at home care setting, when we use NIV, when the patient complains of symptoms of fatigue, dyspnea, morning headache, hypersomnolence, or cognitive dysfunction. And the physiological criteria includes when PaCO2 more than equal to 45, nocturnal desaturations of less than 88% for 5 consecutive minutes, maximum inspiratory pressures less than 60, FVC less than 50% of the predicted value. In severe COPD patients presented with complaints of optimal therapy with bronchodilators, oxygen, and other therapy, COPD patients demonstrate fatigue, dyspnea, morning headache, hypersomnolence, and with physiological criteria, PaCO2 more than 55 or PaCO2 between 50 to 54 with desaturation less than 88% for 5 consecutive minutes, or in the patients with PaCO2 between 50 to 54 with recurrent hospitalization because of the hypercapnic respiratory failures, more than 2 hospitalizations within 12-month period. Other patients, category with nocturnal hypoventilation, obstructive sleep apnea, obesity hypoventilation, idiopathic hypoventilation, patients complains of fatigue, morning headache, hypersomnolence with polysomnographic evidence of OSA not responding to CPAP therapy. Next is what are the steps for initiating NIV? Place the patient in upright or sitting position and carefully explain the NIV procedure, including the goals and possible complications to the patient. Using the sizing gauge, make sure the proper size of the mask should be chosen. Attach the interface and circuit to the ventilator. Turn on ventilator and adjust it initially to low pressure settings. Hold or allow the patient to hold the mask gently to the face until the patient becomes comfortable with it, and encourage the patient for proper breathing technique. Monitor oxygen saturation and adjust FiO2. Secure the mask to the patient and do not make straps too tight. Titrate the inspiratory positive airway pressure and expiratory positive airway pressure to achieve patient comfort. Adequate exhaled tidal volume and synchrony with the ventilator. Monitor the peak airway pressure delivered. Focus on achieving adequate tidal volumes, that is 5 to 10 ml per kg. It means don't forget the patients after applying the BiPAP. Assess for the tidal volume achieved by the patient. Start IPAP at 10 centimeter and EPAP at 5 centimeter of water. Increase by 2 centimeter if hypercapnia persists. Increase IPAP and EPAP both by 2 centimeters if hypoxemia persists. Maximum IPAP limited to 20 to 25 centimeter of water and EPAP limited to 10 to 15 centimeter of water. Backup respiratory rate at 12 to 16 breaths per minute. Check for leaks and adjust the strips if necessary. Monitor respiratory rate, heart rate, level of dyspnea, oxygen saturation, minute ventilation, and exhale tidal volume. Then obtain blood gas values after 1 hour. Now, what are the predictors for success of NIV? Higher level of consciousness, younger age, less severe illness with no comorbidities, less severe gas exchange abnormalities, that is pH less than 7.1 or between 7.1 to 7.35, arterial CO2 less than 92 mm of mercury, minimal air leak around the interface, intact dentition, synchronous breathing effort with ventilator, lower quantity of secretions, absence of pneumonia, positive initial response to NIV within 1 to 2 hours, correction of pH, decreased respiratory rate, and reduced PaCO2. What are the criteria for terminating NIV or switching to invasive ventilation? First is worsening pH and arterial PaCO2, tachypnea, persistent tachypnea more than 30 breaths per minute, hemodynamic instability, decreased level of consciousness, inability to clear secretions or inability to tolerate interface, persistent hypoxia. Now, what are the complications associated with mask and NIV therapy? If there is mask discomfort, corrective action should be taken. Check the mask size and fit. If excessive leak around the mask, minimize the headgear tension. If there are pressure sores, use spacers or switch mask style. Use wound care dressing over the nasal bridge. If there is nasal or oral dryness or congestion, add or increase humidification. Irrigate nasal passages with saline. Apply topical decongestant. Use a chin strap to keep the mouth closed or change to full face mask. If there is aerophagia or distension, gastric distension because of mask, use lowest effective pressures for adequate tidal volume delivery. Use semithicone agents. If there is risk of aspiration, adhere to the proper selection of the patient who can protect their airway. If there is mucus plugging, ensure adequate patient hydration, adequate humidification, avoid excessive oxygen flow rates, avoid short breaks from NIV to permit directed coughing techniques. If hypotension, avoid excessive high peak pressures. Next is advantages, disadvantages of various interfaces. Most likely we use in acute care settings are full face mask and total face mask. Full face mask, it reduces the advantages are it reduces the air leakage through the mouth and less airway resistance. But full face mask causes increased risk of aspiration, asphyxia, increased dead space, claustrophobia, difficult to secure and fit, facial skin irritation, ulceration over the nose bridge, and must have to remove to eat and speak. Total face mask, it has no pressure over nasal bridge, but it has disadvantages of increased dead space and claustrophobia. Other masks, like nasal mask, NIV helmets, and nasal pillows. Nasal mask and nasal pillows are used in can be used in chronic care settings. It is easy to fit and secure to the patient's face, less feeling of claustrophobia, low risk of aspiration. Patient can cough and clear secretions and maintain ability to speak and eat, less mechanical dead space. But disadvantages with this interfaces are mouth leaks, eye irritation, facial skin irritation, ulceration over nose bridge, oral dryness, nasal congestion, and increased resistance through nasal passages. With nasal helmet, advantages are less resistance to gas flow, less need for patient cooperation, less interference with speech and coughing, less skin breakdown. And disadvantages with helmet are CO2 rebreathing, less efficient in decreasing the inspiratory work of breathing, increases patient ventilator asynchrony. With nasal pillows, advantages are same like nasal mask. It facilitates communication, less feeling of claustrophobia, low risk of aspiration, patient can cough and clear secretions, low risk of CO2 rebreathing, no headgear requirement. And the disadvantages with nasal pillows are pressure sores over the nares, nasal air leaking, hypersalivation, and possible orthodontic deformities. Next is modes of ventilation. We have various modes of ventilation, including volume modes and pressure modes, but most likely we use pressure modes for non-invasive ventilations. So most commonly used modes are CPAP, bilevel, positive airway pressure, pressure control, and VAPS. CPAP is usually useful in the patient with congestive heart failure and OSA. Bilevel positive airway pressure, most commonly used, and it requires provision of IPAP and EPAP. Difference between IPAP and EPAP is a reflection of amount of pressure support ventilation provided to the patient. EPAP is synonymous with PEEP. Pressure control ventilation, both inspiratory pressure and inspiratory time are fixed, and this mode is useful in the patients with neuromuscular diseases who do not have respiratory muscle strength to generate adequate inspiratory time. Settings are increased. Inspiratory time may increase tidal volume, but it may increase patient ventilator desynchrony if the set inspiratory time is longer than the patient desired inspiratory time. EVAPS is average volume of assured pressure support, and it can be used in COPD, neuromuscular disease patient, and severe obesity hyperventilation syndrome. It allows target tidal volume with a range of pressure support setting that fluctuate to meet the target tidal volume. Parameters that are part of EVAPS settings are P maximum, pressure minimum, target tidal volume, respiratory rate, EPAP, and inspiratory time.
What is NIV failure?
NIV failure, sir, if we find that patient consciousness is not improving, worsening of other parameters, CO2, increase in the CO2 levels, or other types of hemodynamic instability, desaturation.
We expect one or two of NIV support, decrease level or increase PS around in other.
Sorry, sir, please repeat.
When Proton should get resolution NIV, after 1 or 2 hours we used to get deviation. So we expecting some increase in CO2 level or increase in PS around.
Sir, a percentage of improvement is not given everywhere, but we should check for the definitely decrease from prior level, CO2 decrease from the prior level, improvement in the pH, improvement in the consciousness level, and percentage of improvement is not meant. Improvement in the respiratory rate, dyspnea. These are the predictors.
Thank you, Dr. Sana. We can ask question on the workstation now. So can we proceed to workstation? We can conclude the session now. Thank you, everyone.
Thank you, chairpersons. Thank you, Dr. Sana.
So I think it has been a very hectic day, and I hope everyone has taken something home for you to implement in your clinical practice. We will conclude today with workstations. So before I describe briefly about the workstations, two important announcements. We are having fantastic lectures tomorrow, and I request you to be on time. The session starts at 9:30 tomorrow. And please take something down from each and every lecture. We have a quiz with an iPad, and I really look forward to a lot of participation. So the prelim round will be somewhere in the morning. So I wish you all to be here. And the second announcement is that after this grueling day today, please, you are most welcome for a dinner at Hotel Lalit from 7:30 onwards. So you don't need to go back home. You can move straight from here to Hotel Lalit, which is very close by, just hardly 10 minutes by road, like 5 minutes probably. So, and the dinner, the menu is excellent. This chef is very famous, and an iconic dinner is getting prepared. So I really welcome you to Lalit. You can just move from here to Lalit directly also. Now, the most important part is the workstations. We will be dividing into groups of 5. So there are 5 stations. One is the ABG station right here, taken over by Dr. Nitika. I wanted to invite Dr. Nitika. Please take over your station here. At the back side of your hall is the ECG station, which will be taken over by Dr. Govind. And outside we have 3 stations. One is the 2D echo,